Okay, welcome everybody then. I'm Councillor Colin Stewart. I'm the Vice Chair of the Perth and Kinross Integration Joint Board of the Health and Social Care Partnership. I am sitting in the chair today. Stephen Hay, our chair, intimated his notice to the Board of NHS Tayside. Consequently, he can't be on the Integration Joint Board, so I'm stepping in to that role for the moment. Do we have any apologies?
Thank you, Chair. We do have apologies. We have apologies from Councillor Xander McDade, but we have Councillor Tom McEwen substituting. We have apologies from Lorna Burr-Stewart, but we have John Brown substituting. We have apologies from Dr. Daniel Carey and apologies from Fiona Fraser.
Okay, thank you very much, Gillian. Perhaps I should introduce the rest of the people up here. So on my left, I've got Rob Packham, the Chief Officer of the Integration Joint Board, and Jane Smith, the Chief Financial Officer of the Board. And on my right, Gillian Taylor, the Clerk to the Board, and Scott Hendry, from Committee Services at Perth and Kinross Council. And we're very happy to welcome John Brown, the Chairman of the Board of NHS Tayside, substituting for one of the NHS Tayside members today. Can I check, first of all, some housekeeping matters. Can I make sure that everybody's got any loud mobile phone or electronic devices switched into a silent mode? Better do that myself. There are no fire alarms planned for today. So if the alarm does go, then we'll exit via the nearest available exit, and the meeting point is the viewpoint on at the end of on Tay Street at the end of the High Street. Item 2 on the agenda: declarations of interest. Does anybody have any declarations of interest in matters on the agenda before the board today? Mrs. Gallagher.
Yes, thank you. I've just want to declare a non-financial interest on agenda item 5.2. Appendix 1 is a report that was produced by Independent Advocacy, which I'm employed by.
Okay, thank you very much. Are there any other declarations of interest? No. We'll then move on to finance and governance. With the permission of the board, I'm going to reorganise the agenda slightly. I'm going to bring forward the verbal update, the Audit and Performance Committee item 3.8, and take that under at the same time as 3.1 and 3.2. We have before us the annual accounts of the IJB. These have been to the Audit and Performance Committee, and so I'd like to firstly hand over to Councillor Purvis, who's our Chair of the Audit and Performance Committee, to give some introductory remarks on the annual accounts, and then Jane Smith, the Chief Financial Officer, will be available to answer any questions. Councillor Purvis.
Okay, thank you, Chair. Just before I come on to the annual accounts, I'll just go through some of the other updates from the Audit and Performance Committee. I'd first like to take the opportunity to thank Councillor Chris Ahern for his efforts when he was Chair of the Audit and Performance Committee. Having now taken over as Chair of the Audit and Performance Committee from July, I'm keen to ensure that it is thorough in its scrutiny of the finance, governance and performance of the Health and Social Care Partnership, and provides assurance to the Perth and Kinross Integration Joint Board. I would like to build on the improved transparency of the IJB that has come from the recording of meetings, and have asked for the same to be done for meetings of the Audit and Performance Committee. The Chair will shortly be seeking the Board's agreement to this suggestion. Moreover, we are currently in the process of reviewing the terms of reference of the Audit and Performance Committee to refine the role of the committee in providing assurance to the IJB, and the Chief Internal Auditor has set aside time to assist with this process. It should be noted that this work is taking place alongside a review of the IJB's standing orders. While some changes may be more procedural, there are others that concern making clear where particular issues should be considered within the structures of the IJB, such as complaints handling, whistleblowing and public engagement. There is also a need to decide where issues relating to clinical care and professional governance should be dealt with. The Audit and Performance Committee previously agreed to set up a subcommittee for such matters, but there is an alternative option of setting up a separate committee of the IGB for this purpose, as has been done in other local authority areas. The revised terms of reference for the Audit and Performance Committee and then updated standing orders will be brought forward to a future meeting of the Audit and Performance Committee and the IGB for consideration. In terms of the substantive items considered by the Audit and Performance Committee that were considered at our last meeting, we received an update on the last year's internal audit plan and considered the one for 2018-19. We also received a progress update on the review of risk management framework, which seeks to give greater clarity around the escalation and mitigations of risks. As part of the review, a workshop on this subject will be held for all IGB members in November, with a view to bringing an updated framework to the next Audit and Performance Committee for approval. In addition, there are two items that we considered that I should like to focus on in particular and bring to the board's attention. The IGB's annual governance statement notes that we are reliant on both our partner organisations to achieve our aims and objectives. Each year, we therefore seek assurance from both Perth and Kinross Council and NHS Tayside that their governance arrangements are robust. The Audit and Performance Committee received a letter of assurance from the Chair of the Audit Committee of Perth and Kinross Council, confirming that the Council's governance arrangements were legally compliant, ethically sound, and fit for purpose for 2017-18. Unfortunately, we did not receive a letter of assurance for 2017-18 from NHS Tayside. The report before the Audit and Performance Committee highlighted comments from the Chief Executive of NHS Tayside, which stated that he was not able to conclude that corporate governance was operating effectively throughout the financial year to the end of March 2018. The Chief Executive of NHS Tayside has, however, instigated action to address the recommendations made in the Insurance and Advisory Group and Grant Thornton reports, and has commissioned an independent risk assessment of board governance and an independent review of the effectiveness of internal audit. NHS Tayside position in 2017-18 clearly does not provide the board with the assurance that we would usually expect from one of our partners. There is, however, evidence that remedial action is underway, and I would like to think that soon we will be in a position where both partners will be able to provide assurance to the IGB of the adequacy of their governance arrangements. Moving on to the annual accounts, as Councillor Stewart referenced, these were considered at the IGB's Audit and Performance Committee, and we have been able to recommend them to the board for approval at today's meeting. Our ability to make that recommendation was informed primarily by the IJB's external audit annual report, which has been carried out by KPMG, and a copy of which is also in your papers today. KPMG also attended our meeting to take the committee through the report in greater detail and answer any questions that members might have. My colleague Councillor Drysdale raised a concern about the lack of reference in the external annual audit report to the significant number of changes in members of the IJB since its inception as a potential risk to the board, and representatives from KPMG agreed to update the report to include this. The key findings from the report are summarised in report 3.1 today, but overall it concluded that the IJB had appropriate arrangements in place to use resources effectively and to continue to improve services. The report stated that the IJB has strong scrutiny and governance arrangements in place, and that we have robust controls over the monitoring of expenditure against our budget. The external auditors also welcomed the development of a 3-year revenue budget to help plan for future pressures. KPMG were satisfied that the IJB remains financially sustainable, but acknowledged the financial pressures facing both partner organisations and the fact that the integration scheme may require them to make further contributions in the future. The external auditors also agreed with a statement by officers that further support is required to ensure the IJB's financial capacity is adequate in order to deliver on savings and effectively direct all services. On the basis of the findings of KPMG's external audit annual report and the other information available to us, the Audit and Performance Committee were able to recommend the audited annual accounts for 2017-18 for approval today. Thanks.
Thank you, Councillor Purvis. So, just returning to the first point that Councillor Purvis raised, before we move on, can I then seek the board's permission? In line with recording of meetings of the Integration Joint Board, the board is asked to consider whether it wishes to amend standing orders and record meetings of the Audit and Performance Committee for public viewing online following those meetings. Is that acceptable to the board? Yep. Okay, thank you very much. So we'll return to the issue of the accounts, and Mrs Smith, would you have any further commentary to make on the accounts, or are we happy to move to questions? Okay, any questions on the accounts? Councillor Drysdale.
Can I just clarify that this question session includes questions relative to the KPMG external report? Yeah, yeah.
Absolutely.
Thank you. As Councillor Purvis has indicated, when we spoke at the Audit and Performance Committee, there was a request to amend the external report to make reference to the significant number of changes in personnel within the IJB and the effect that, if there was any effect that might have had on governance during the year under review and since. Unless I've missed it, I don't see that change. And apologies in advance if there has been a change, but I just couldn't see it when going through the papers again.
Mrs Smith.
Apologies. We may need to double check that we have the
The papers were released on Friday and the committee was only on Thursday, so...
So for clarity, the final report will contain a reference to that.
The final report submitted to Audit Scotland will absolutely contain the changes. Yeah.
Thank you. If I may just add a further comment on a separate issue.
Please, Councillor Drysdale.
A comment rather than a question, but I would just like to draw to the attention of members who are not on the Audit and Performance Committee something that Councillor Purvis has already spoken about, which is on page 28 of your papers, and the comments of KPMG on the financial sustainability of the IJB. Carefully worded statements undergoing concern and conclusion, which make it very clear that, and I quote, if I can find it again, we remain, it says we remaining, but I suppose it means we remain satisfied that the IJB is financially sustainable in the short term as a result of the ongoing commitment of the two joint venture partners. And I just want to flag up that short-term bit so that everybody is clear on what KPMG are saying here. Thank you.
Thank you, Councillor Drysdale. Are there any other? Mr Brown.
Chair, thank you. Just firstly, picking up on Councillor's feedback from the Audit and Performance Committee, I'd like to give the IJB members the reassurance the NHS Tayside Board will be considering the improvements to the governance system within the Health Board at our meeting on the 26th of October. And I would expect that shortly after that we would be able to give the IJB the assurance that it's looking for around the levels of governance in the NHS in Tayside. I've got a couple of questions, and apologies given that I'm sort of late to the party, wasn't here last year, on this particular report in the paper. I noticed when we describe the financial situation at the end of the year, there's an explanation of where the health overspend has come from. There isn't an explanation of where the social care underspend, which, when you consider the health overspend is 0.8% of the overall budget, but the social care underspend is 5% of the overall budget. I would have expected to have seen some explanation of that in the audit report. I suspect, well, I know that you'll have debated the reasons for this in the past, but I think from a governance point of view, from a transparency point of view, the report's incomplete because it doesn't have that. My other observation on it, and I'm puzzled slightly, is the reserves. In the report at one point, page 5, talks about if there's an underspend at the year end, it's retained by IJB as reserves. And that, I know, is common practice across Scotland. But in Perth and Kinross, not all the underspend seems to have been made available as a reserve to the IJB, if I'm reading this properly. And PKC Council has earmarked reserves of 1.2 million. And when you look at the following year's financial report, the current year's financial report, that 1.2 million doesn't seem to have been made available. So I just don't see how this hangs together.
Mrs. Smith?
If I can take both points, I mean, obviously KPMG are not here to respond to the specific point, but it's absolutely, I think, a legitimate point to recognise that the underspend is not in the report, and perhaps it should have been, and we'll certainly feed that back. In terms of the underspend and the reserve created on the back of that, that was withdrawn and retained by PKC after discussion. It is not fed into financial position at the moment, you're absolutely right. We have discussions ongoing with PKC colleagues around financial recovery for the social care part of the IGB's budget, and one of the first points of discussion for a meeting that we will have next week will be the utilisation of the balance of that £1.2 million reserve. The reserve, the current balance currently sits after the use of that reserve for voluntary severance costs for Beech Grove residential home closure at just under £600,000, and that will be considered as part of the wider financial recovery plan discussions.
Thank you for that. Can I just confirm then that the retention of this 1.2 million was with the agreement of the partners, so with the agreement of the IJB and the Health Board at the time?
Mrs. Smith?
I think it's fair to say that the discussions that were held about the reserve were not with both partners, they were with the partnership team and with Perth and Kinross Council.
Okay, thank you for clarifying that.
Okay, are there Councillor McEwen and then, oh sorry, Councillor McEwen.
Well, looking at page 47 of our papers, which is the page 7 of the actual document, there's a table there, table 1, which looks at the Ministerial Strategy Group indicators. And I suppose what I want initially is a bit of clarity over the comparative figures, because depending on that clarity depends on the question I ask. We have a total previous year figures, and the comparator seems to be year-to-date figures for this financial year. And I'm not sure that if that is the case, that would be an appropriate comparator to then give us all these green indicators on the table. The reason being is that health services are much more under pressure and busier during the winter months, and therefore it's likely that most of those figures will actually turn red when you're comparing total year to total year.
Mr. Packham.
Thank you, Councillor McEwen. I'm probably not in a position to discuss the detail of this. However, what we did in this last year was to look at the changes that have happened relative to the previous year. And we are seeing marginal reductions, as you can see, in some of the measures there. However, some of our activity is within P&K on these measures it's quite difficult to be specific about. And you know, for instance, you know, we've seen some changes in the profile of services within P&K in the emergency medicine provision. So the number of beds that have been there, the ways in which the services have been organised. So there's been a huge state of flux as we've been going through this. But in trying to, I suppose, address your point here, these figures are worked through with our colleagues from ISD, the list technicians from the Information Services Division, and we have to rely upon these as they stand at the moment. However, our ability to adjust and improve on these is really just coming to the fore now. We are working now in 4 care streams, as you're going to hear later, and we're expecting that our performance should increase or improve significantly in this coming year, simply because we're giving specific focus to the older people in unscheduled care element of our work in particular. I'm not sure if that fully answers your question. If not, please try again.
You've sort of said to me that you don't know if those 2 columns are comparators, that they're apples and apples. They look to me like they're apples and pears. And you look at the emergency admissions 1A, they're virtually identical with a small difference.
Yeah.
But we've still got 6 months of the year to go. And then you're looking at unscheduled hospital bed days and things like that. These things are a reduction on these figures, but if we're comparing a whole year with 6 months of a year, then that's not comparative.
Apologies, just to we are absolutely comparing 12 months with 12 months.
Yeah.
This is comparing 16-17 with the full period of 17-18. We're now into 18-19. So it is a direct comparison of 12 months data. So we're absolutely comparing apples with apples. Yeah.
Thank you. Sorry. Yeah.
Okay, thank you. Mrs. Gallagher.
Thank you, Chair. Yes, I have a question on the KPMG recommendation in relation to workforce planning. It states in the audit report that management are aware of the risk of a shrinking workforce and plans are being developed that will manage the future workforce. Recommendation 3 of the report states that to mitigate the uncertainty risk surrounding pay increases, the IJB included in its 5-year plan the assumption that pay increases for NH staff will be similar to that agreed to council staff. So with this in mind, the Third Sector Strategic Forum has a concern going forward that a significant pay gap may appear between statutory and third sector, and that and the impact of that may be an imbalanced shrinkage of workforce impacting on services. So our question really is around the possibilities of participating in discussions around workforce planning.
Mr. Packham.
Thank you, Claire. Yes, we'd be very happy to involve you in that process. And in fact, just yesterday, we were beginning to have a discussion with our colleagues in the independent sector. So we will open that up. The idea is that we've got to look long-term at a shift in the balance of workforce. We know that we're very short of certain types of professional staff, nursing in particular, some forms of medical specialists as well. But as we get out into putting more work into early anticipation prevention, we are going to rely much more heavily on our third sector colleagues. So Diane Fraser and I met with the Third Sector Forum here in Perth and Kinross, and we were very keen to explore with them what the possibilities are. But we do need to work within the boundaries of professional regulation, so we'll be needing to be very clear about the types of work that can be done by different contributors to the whole patient pathway. But we see the future will be very much more closely integrated with the third sector, and I would see an increase, I would expect, in the third sector workforce in comparison to our statutory partners. So I know, for instance, here in Perth and Kinross, we have 900 contributors to the health and well-being of the population above the roughly 1,800 people that we have who are either employed directly by us or through us. Thank you.
Okay, Dr. Noble.
Thank you. Can I just do a wee bit of history before we go down this road? I'm quite worried that we're starting to hear things that remind me of Perth and Kinross together, and we're almost getting to 3 organisations rather than an integration model. And the whole point of the integration model was to have a shared budget and a shared understanding of clinical care, and to clarify that relationship between what is community care and what is hospital care. And if we're not careful, we're going to end up back in what position I wouldn't like to see you getting into, of having 3 organisations when in fact we were trying to integrate 2. And in particular, just to pick up the point about the numbers, because I think we have to use real data, and just to ask a couple of questions. Has any money moved from, let's call it hospital care, as we've reduced the delayed discharges? And if not, why not? And 2, do the localities understand where they stand around this P&K data set, which I still think is the key to the solution for all these problems?
Mrs. Smith?
Taking both points. The first point about shifting the balance and understanding the level of shift we can see from the financial plan that we have brought forward to the IJB, very clearly set out our intention around investment and disinvestment. Some of our key investments have gone in to shifting the balance through some of the investment in the front door, in our at the hospital, which is not about inpatient care, it's about moving patients out, in our heart team, in our intermediate care teams out in the community. So we can see through the financial planning process investment going in. At the same time, however, we all know the challenge of delivering financial savings, and unfortunately there's a very significant disinvestment plan as well, which sees significant disinvestment across social care services. The social care transformation and efficiency strategy alone for 18-19 takes out £4.6 million worth of savings. Now, some of that, significant amount of that is transformational and efficiency, but clearly some of the discussions we've had is that that level of budget cut starts to impact or will start to impact on services. So if on one hand we are trying to do what sits at the heart of integration in terms of our investment strategy, but on the other hand we are required to retain financial balance, and we have to disinvest in social care in the same way that we have to in healthcare, and we have having to disinvest £4.6 million worth of community and social care investment in 18-19. In terms of your second point, Alistair, apologies, I have lost the thread on your second point.
Just to emphasise, I mean, my understanding, and you know this is a long-held position, that the clinical decision is the purchasing decision. So if we decide somebody should be looked after in the community, and that's what everybody's agreed is the best thing, that's where the money should go. And if we decide they should be looked after in hospital, that's where the money should go. And as you know, I've long argued that that should be based on the locality's understanding of their clinical activity. And the point I was making, Dan, and I think it's important, that my sense is that we're creeping back towards what went wrong with Perth and Kinross together, where we're discussing it as if there's an IGB budget, a health board budget, and a Perth and Kinross budget. And the whole point of this was to get into the nitty-gritty of how an integrated, fair share locality budget copes with the pressures we all understand that are there. And that will throw up the questions that I think need to be answered around what is the correct clinical activity per locality for Perth and Kinross.
If I could come back then, Alistair, and then hand over to Rob. I mean, I think what you say is accurate in terms of where we have been over the last 2 years, in terms of the discussion together with both parent bodies about an integrated budget. I think that the change in leadership at NHST side will allow a much more strengthened and collaborative approach to those discussions, and we've already had some very useful and collaborative discussions with both NHST side colleagues and PCC colleagues together in the room for the first time probably since for the last 2.5 years. We're starting to have joint discussions about our joint ambitions for the Integration Joint Board.
Thanks. And Alistair, if I could just add the following. There's been an awful lot of discussion in the recent few months around our planning and about the way in which we're going to take things further forward. So you're going to be hearing a little later as I go through my update about new care streams and care programming approaches, which will look at an integrated method of bringing together the thinking about shifting the balance of care and achieving the objectives of the partnership. But adding to that, we have to remember that the Integration Joint Board is about bringing together the two major partners in a common endeavour. So we've recently seen the appointment of Anne Erickson in the Health Board to take a strategic planning lead, and we're going to be working extremely closely with Anne. In fact, the emphasis that's been coming from the Health Board is that the whole system needs to be planned together and that we need to see continuity of care across all of the pathways. For example, we've just recently arranged that Anne will join us in having a discussion about how our strategic planning process and the acute planning process will come together. And in mental health, we've recently appointed a new leadership team to mental health, and they will be planning in a more integrated way across the 3 IJBs in the acute sector to make sure that we have continuity of care. So in terms of the Fair Share paper that was produced, I think, in 2014, we've recently revisited that. We've been having a look at the principles which are not lost to us, and we are obviously going to make sure that as we look at the 4 care programs, we will find some method of balancing the expenditure across the 4 care programs to make sure that we address the issues of inequality and moving far more towards early intervention, prevention, and anticipation.
Dr. Noble.
Just to say, I mean, I welcome this. I mean, I genuinely think this is a wonderful opportunity for NHS Tayside and Perth and Kinross to get this right. And just to emphasise, I think most of the donkey work has already been done. We now have to face the hard decisions that we have to look at individuals, look at localities and look at their performance. And if we do what's best for the individual patient, we'll end up with a very different distribution of care. And as you know, I strongly supported your mental health reorganisation, which I think is the model that we're working on. And we need to do something very similar around what we would call acute medicine for the over 65s. And just to remind everybody that, you know, when we do audit, something like 50% of the occupied bed days shouldn't be in hospital. And we've got delayed discharges at roughly 1 patient in 5. That doesn't strike me as being incredibly good use of resources. But more than that, it's bad for the individual patient. So if we concentrate on the individual patient and build up the community teams, then I think there is a way forward that would really make this work and work much more quickly and would be much easier to defend in public for both the councillors and NHS board members, because actually what you're doing is providing best care for each individual and giving them that quality reassurance at their locality and at the hospital level. Thank you.
Thank you, Dr. Noble. I mean, we have seen a reduction in the number of inappropriate admissions to hospital. We're seeing a reduction in the number of lost occupied bed days here in Perth and Kinross. So it is beginning to change. And there is an attention now to having an integrated way of looking at the whole care pathways. And we've recently commissioned Deloitte to help us look at the future use of the community hospitals and to get that balance right between acute care, care that's delivered out of community hospitals, and that which can be delivered through the primary care team and in the patient's own home. So this is absolutely at the core of the thinking of these care programs. And you know, we're seeing that now moving at pace because we're bringing together not only the clinical thinking but also the financial planning that surrounds that.
Thank you, Mr. Packham. If I could just add something there, Dr. Noble, in terms of issues around, for example, delayed discharge, the board at its last development session visited PRI, and we got very briefly to talk to the discharge hub nursing team up at PRI. But following that, separately, myself and Councillor Purvis visited HEART, the Home Assessment and Recovery team, and it looks like from our engagement with them, I would say that was showing a genuinely transformational change in getting patients more quickly out of hospital and into a comfortable and properly equipped setting. And certainly the figures that we saw in terms of delayed discharges were definitely heading in the right direction. But they were fully connected with the discharge hub nurses. The other point that you raised, the first point that you raised was about the integration generally of health and social care. And I know that one of the things that we're looking forward to towards the final quarter of this year, correct me if I'm wrong, is the joint workforce arrangements and protocols between the health staff and the social care staff, which will hopefully lead to a much greater integration, I think, along the lines that you were talking about. Mr. Brown again.
I'd just like to support what Dr. Noble was saying there about the clear intention is to run this as one health and social care system. It's not to have three organisations trying to run it, it's to be run as one. I'd like to give IGB a bit of assurance in that space. I don't know if you'll have seen the letter yet, because it just came out earlier this week from the Cabinet Secretary and the Chair of COSLA, following discussions at the Ministerial Steering Group, where there was a very clear message that the expectation is that we will have an integrated system, it will be run as one, and we will be jointly accountable for the delivery of that. I'd also like to say that the Cabinet Secretary has made it very clear to all health boards in Scotland, I was at a meeting with her on Monday, that she has three clear priorities. One is to improve service. I think, again, that goes back to what Dr. Noble was saying about having that focus on the patient. The second one is about speeding up the pace of integration, because without that integration, we won't improve the service. And if you take bed days as an example, the delayed discharge bed days, whatever way you want to cost that, whether you cost that at £200 a day or the £420 a day, in the government's figures, for Perth and Kinross, you're talking millions of pounds being spent in acute services. The A isn't good patient care, and B, acute services don't have the budget for it. Yeah, that's part of the problem in the financial predicament that Tayside Health Board finds itself in, that money has been spent unnecessarily because we haven't speeded up the pace of integration. We haven't got more people being cared for in the community. People are still going into hospital when they don't have to, and staying in hospital longer than they should. So I totally support the theme that's been presented here today, and I'd like to give you the assurance that the board is very much behind that.
Thank you, Mr. Brown. It's worth just mentioning as well that the Cabinet Secretary's letter wasn't just to the health boards, it was to the council leaders, chief executives, the IJB chairs and vice chairs, sending a very sort of clear direction from COSLA and from the Scottish Government to all of the partners across the public sector in that respect. Are there any more questions or comments on the annual accounts? If not, then can
Apologies, Chair. I wonder if I could ask.
Councillor Drysdale.
Yeah, I wonder if I could ask if the said letter from the Cabinet Secretary can be shared with IJB members, please.
It just came in this week, but yeah, I think absolutely we'll make sure that that is circulated to all of the IJB members. Another last-minute bite at the cherry, Councillor Drysdale? No? Okay. If there are no more questions or comments on the accounts, then
My Colombo moment.
could I ask if the board is happy to note that the Audit and Performance Committee considered the annual accounts and KPMG's annual audit report at its meeting on the 20th of September, that we've considered the contents of KPMG's audit report and the Controller of Audit on the 2017-18 audit, and are we happy to approve the audited annual accounts for 2017-18? Yep. General agreement. Thank you very much. One second. Right, okay. So if you'll note from the agenda, there's to be a short break for the signing of the annual accounts. That comes after we've heard from the Chief Financial Officer on the 2018-19 financial position. We do have to sign the accounts and send them away to KPMG. So I'd propose, if the board's happy with that, that we'll take the recess now to sign the accounts. And then, because I suspect that there might be a few questions on the year-end financial position, and then we'll come back and take item 3.2 on the agenda, if that's all right. Yep, great, okay. So we'll take hopefully just a 15-minute recess until 10:30. Okay. So if we reconvene now, thank you very much. We'll then continue with the agenda. We haven't even yet got onto the minutes of the last meeting, but we'll do that and start the meeting in normal order in a second after we look at 3.2, the 2018-19 financial position, report by the Chief Financial Officer. It is probably worth noting in particular the prescribing overspends and social care overspend that has already been mentioned in the meeting this morning. And obviously the social care overspend has developed from an underspend position last year, but the prescribing overspend is a similar overspend to last year, and actions will need to be accelerated in order to address that. But perhaps I could get the Chief Financial Officer to introduce the, make some comments on the paper, and then we'll move to any questions.
Thank you, Chair. Just to remind members that the paper that came to the IJB in June, the forward look for the financial year highlighted significant financial risks that were quantified at around about £4.1 million. And now, as we forecast for the first time, based on actual expenditure to the end of July, so for the first 4 months, we're forecasting an overspend of £3.2 million. As the Chairman has said, that splits into 3 main elements: an overspend on social care of £1.4 million, an overspend on prescribing, which is just under £900,000, and an overspend on our hosted services, of which the key component part is our inpatient mental health services of £832,000. As our Chair has mentioned, the position on social care is a major switch from last year. Colleagues will recall, and we've already referred to it in the annual accounts, a very significant underspend reported last year. But colleagues will also remember that of that underspend, without exception, it related to the non-recurring benefit of accelerated savings in advance of the significant transformation programme that we are required to deliver in this financial year. So those benefits are no longer there, and we move into a position where we have no or very little non-recurring offsets. So on the social care position, the significant demand pressures that are coming through this year, a level of undelivered savings that are coming through this year, there is nothing there now to offset that. These overspends are entirely unanticipated. The most significant relates to the complex care of our mental health and learning disability clients. That has arisen in terms of numbers and in terms of the complexity of these clients. We've done a deep dive into that and have a full understanding of what has driven that increase in costs, and it couldn't have been anticipated. The other major demand pressure within social care is in relation to care at home, and that's a significant turnaround from last year, where we saw an underspend on care at home. We're now seeing a significant overspend in demand for care at home services, well beyond our expectation. In addition, the use of interim placements, short-term placements used to bring our patients out of hospital when they're ready to go, when a care home placement, a package is not available, Last year that became part of the patient pathway, but was offset by the underspend on care at home. That underspend is no longer there, yet we're continuing to use interim placements to improve capacity and flow from PRI in particular. So those some significant unanticipated pressures. The integration scheme, section 9.2 of the integration scheme, sets out that there is an opportunity with both parent bodies to have discussions in year around unanticipated pressures and to have a discussion about the possibility of additional budget being released. So as we move to have discussions with our PKC colleagues around our recovery plan, which has been requested by Perth and Kinross Council from the Chief Officer and the Chief Finance Officer, one of the first things that we will discuss is section 9.2 of the integration scheme. The first meeting in that respect is next week with Karen Reid from PKC. But of course, as part of that agenda, we will also be required to discuss the potentially difficult decisions that may require to be taken to bring the social care position back into financial balance. What I would highlight is that the underlying pressures that we're facing are undoubtedly going to make the financial position going into next year that bit more difficult. And the scale of demand and cost pressures that we face going into next year, I think, is beyond anything that we would have predicted. But as we bring back the financial planning, the 3-year financial plan to our IGB members over the next few weeks and months, we will take the time to go through that with members. For our core health, hospital and community services, we're forecasting break-even, which is good news. But for prescribing, it's worth mentioning for prescribing that the current forecast is based on plan. It does not yet reflect any in-year expenditure. We are working with our colleagues in NHS side to get a more robust forecast, but it's important to say that the information we have at this point, we know that forecast will deteriorate. The main reason that we're aware of at this stage is due to the fact that the Scottish Government have removed from NHS side £1.8 million in respect of the board's global sum contribution to drug tariff benefit for community pharmacists. And that's in response to the shift on prescribing on pregabalin, which was part of our savings plan for last year. That shift in the loss of profits to the community pharmacists has led to a renegotiation that sees budget going back to restore a profit level. That £1.8 million reduction to NHS side, we're expecting that will be passed on to the 3 IJBs, and our share of that will be £355,000. So we will instantly see a deterioration in our forecast position on the back of that. For inpatient mental health, Rob may want to speak to that, but the forecast position is broadly in line with what we expected. However, it's absolutely essential that we find the right route into the new senior leadership team as it's forming to start to set out the key actions, including the transformation programme, but over and above the transformation programme, that are required to bring inpatient mental health services into financial balance.
Thank you, Jane. Yes, very recently, within the last month, we have implemented a new leadership team into the inpatient mental health services. Professor Keith Matthews is the new Associate Medical Director. He's the Professor of Psychiatry in Dundee University. Brings the opportunity for a new form of clinical leadership within the mental health services. He is supported by Mr. Keith Russell, who many of you have met before. Keith is the Associate Nurse Director and brings with him a wealth of experience, not only here in Scotland, but in England, of running complex mental health services. We've also recently appointed Arlene Wood, who's now the Associate Director of Mental Health Transformation. We are thinking at the moment about how this clinical leadership model will work when it is applied to a clinical specialty that is not purely reliant on the medical model of care. So we're looking very hard now at how we broaden the input to that planning process to make sure that from a social care and a social model point of view that we have an appropriate level of input so that as we redesign services, we will be looking at a future sustainable model that will redress some of the remaining imbalance between in and outpatient services. So this is a work in progress, and as you're aware, we started the process of bringing together the general adult psychiatry services on one site, the specialist services on another site, and that will work its way through over the next year or so. However, it is also important to note that in terms of culture and current practices, there is work to be done, and this team will bring that to bear. Now, we're expecting in that new models of recruitment to medical posts will come along, clinical academic careers, for instance, which will reduce our dependency on expensive locum staff. And this will be the primary reason that we can predict that the level of current spending, overspending, should come into balance over time. Thank you.
Thank you both. Are there any questions? Councillor Drysdale.
Thank you, Convener. This is questions mixed with statements. I hope that's in order. I just wanted to say what I want to say and put it on record. I mentioned earlier about the KPMG external auditor's opinion on financial stability, and what we're seeing here is a situation that is not financially stable at the moment, in my opinion. And I'd be interested in comments on from Jane and from Rob on what I'm about to say. I think that there is considerable evidence of performance targets having been overstretching when set, and then obviously there are the unanticipated pressures as well. And only an extreme optimist would suggest now that full year targets are going to be met. Looking to the medium term and beyond, there's currently no sign of a light at the end of the tunnel other than that of an oncoming train. This is not in any way to criticise either IJB members, including myself, or officers for their financial stewardship. We have all faced an immense task in even coming close to balancing the books. And indeed, had it not been for what is euphemistically called staff slippage, i.e. understaffing due to people leaving, and a struggle to replace them even before Brexit arrives and causes further difficulties, the current financial shortfalls would have been even greater. The officers and employees of our two parent organisations, PKC and NHS Tayside, relentlessly still do their best to pursue a challenging transformation agenda is a huge credit to them all. Looking further down the track, there is an even more daunting challenge to be tackled that we have to face, where Perth and Kinross faces forecast growth in our elderly population that well exceeds the national average. So demand for healthcare and social care is only going to increase and increase substantially going forward. As we have heard this morning, the problems are particularly acute looking at our social care services. We're seeing strong resistance to attempts to increase COSLA terms for contributions to care. There are still higher than envisaged demand for care home placements. There's increasing demand for both inpatient placements and community care packages for those with learning difficulties and mental health issues. And there's increased demand for step-down care in order to further unblock delayed hospital discharges where progress is being made. The list goes on, the figures are all in the report. So what are we to do is the question. I tell you what we must do, in my opinion. More financial and human resources urgently need to be found before our creaking health and social care system fractures under this unremitting strain. I've heard this morning about the pace and challenge of the integration system, and from what I've heard, I have increased confidence from the comments from Mr. Brown in particular, that there will be improved integration as we look to tackle these challenges going forward, although we do need better financial information from NHS Tayside to be able to do that. But I call upon both NHS Tayside and PKC to recognise these intense pressures and substantially, and I do mean substantially, look to increase funding of key services that affect all of us, and in particular the most vulnerable in our society. It's about our choices, our priorities as a nation. These organisations, when agreeing their 2019-20 budgets and future year budgets, must make the right choices. And if NHS Tayside cannot do so due to its own financial situation, then the Scottish Government needs to step in with brokerage as it has previously done. We need to sort out this situation once and for all. If we don't, the consequences do not bear thinking about. Thank you.
Thank you, Councillor Drysdale. Do you want to pick up any of those points? Mrs Smith.
Thank you, Chair. If I could just pick up some of the points that you've raised, Councillor Drysdale. I think it's probably important to note that when we brought the financial plan forward at the end of June, it remained out of balance, and it remained out of balance by approximately 2.3 million. That was largely down to prescribing and inpatient mental health. We believed at that point that we had an opportunity to see our other core services in social care and hospital and community health in financial balance. But what we're seeing now is that the predicted overspends on prescribing and inpatient mental health coming through, but the very much unpredicted position on social care, turning this position into a, one that it's far beyond the financial plan. You are right in saying that the level of underlying pressures is higher than the report currently suggests. The underpinning, particularly the social care position, are a number of one-off non-recurring benefits still from backdated income and other such benefits, vacancies in some of our key teams that we expect to recruit to now, and those benefits won't be there moving forward. So as we look to the scale of how these pressures move from being a pressure this year to a pressure in next year, it will increase. What you've described, what we're seeing here is demand pressures. What we're not seeing coming through, because they're largely, we've put money into the budget to fund them, are the unavoidable pay and price pressures that come from the National Care Home contract, the pay that the pay increases to our own staff, etc. And we add those together, and the challenge for next year is enormous. The PKC medium-term financial strategy, which will be considered by the Council next week, and which papers went out publicly, I believe, yesterday, will indicate a level of pressures on social care services for next year of a minimum of £7 million. That's what we're facing for next year.
Thanks, Councillor Drysdale. I'll just add a couple of things to what Jane has said. First of all, I want to acknowledge the accuracy of your predictions around the growth in our population demand here in Perth and Kinross. We absolutely have one of the oldest populations in Scotland in our mix of population. However, we do have a very large number of people who live into old age independently and very well. However, we also have pockets of deprivation within Perth and Kinross that put extraordinary demand upon our system as well. So it's interesting that we're now beginning to see some changing trends. We're beginning to see the discharge of people who've had complex needs, but the cost of the individual care packages for these folk are really significant. Now, I took some time to speak to the mother of one of the people who were serving, and I asked her how it felt to her. And she, first of all, was acknowledging the enormous cost, and she was saying how difficult it is to actually find the right solutions for her family member. And so therefore we have to listen as we find solutions to the people who we are serving. And I'm not convinced that the current model of managing the needs of folk with complex needs is as it should be. So we're about to go into a fairly rigorous conversation about how we might redesign something for the future. And we're going to be referring to models from elsewhere. We're going to be looking at the best practice, and we are engaging the clinical leaders in that process. So this is about how services are designed to fundamentally change. And this brings me to the core principle that we are at the edge of something in the health and social care partnerships. We are being asked to design a new future for things that have always been difficult. So this is a question about how do you sustain people for longer at a higher quality of life in the community without them having to depend upon institutional care. Now, that's going to mean that we need a change in culture, so that when professions and organizations have been based around institutions or buildings, we may need to see that change. And in that culture change, we have the big quest to work with our partners to make sure that whatever we design and deliver for the future remains safe, effective, and good value for money. So in an area of 5,000 square kilometres, where we have two, at least amongst the most 12 rurally isolated areas in Scotland, we have particular challenges for those populations. And then in our prison here, as we serve that population, we see people who are living at probably the most vulnerable of many of the people in our society, and we have responsibility for dealing with all of those. So in our planning and in the 4 care streams that we're designing at this very moment in time, we will be charging those teams to make sure that as they plan forward, they're thinking not only about what's safe and effective, but also what's financially sustainable. We know that we are at the edges of having to cut into things which are really important for people, and it's very important that as we have this discussion, that is understood and supported by not only members of the IJB here, but also by the 2 parent bodies who need to understand the interdependency of one on the other. Because a piece of work that might appear to save here, I'm afraid can sometimes have an effect on the neighbour, which we must take care of if we're truly going to improve services and outcomes for the people that we serve.
Yeah, thank you for these comments, Jane and Rob. I very much appreciate what you're saying and agree with your comments. I just come back to the central point, thrust of what I was trying to say here, that there is tremendous work being done by yourselves and colleagues in both organisations to drive forward this challenging transformation agenda and deliver services that are fit for the 21st century. And I commend you all for that. The fundamental point I'm making is that what is constraining that effort is the lack of finance. And there are 2 bodies, and only 2 bodies, that can rectify that, and I call upon them both to do everything they possibly can to increase investment in health and social care services.
Councillor Purvis.
Thank you, Chair. We touched on this last week, but if I could just ask a bit more about the risk-sharing arrangements between the IJB and our 2 partner organisations. Obviously, the scheme sets out that from year 3, which is 18-19, any allocation of an overspend could be allocated on a proportionate basis, but the paper says that we don't think that that is what we're going to do for this year, and rather it will be based on the partner with operational responsibility. And I suppose to me that seems logical for if they're failing to deliver on transformation, but perhaps it could be argued, in terms of unanticipated demand pressures, the fact that it's a joint budget, that it would make sense to be allocating on a proportionate basis. I suppose my question is, why have we arrived at the decision that that's not the right approach for this year? What is the rationale in the scheme for allocating on a proportionate basis? And is the intention to get to a stage where we will be allocating overspends on a proportionate basis or not?
Mrs. Smith.
Thank you. I mean, I always try to be honest in my responses. The 3rd year is a may. It talks about it may move to a proportionate basis. All of the discussions that we've had as a partnership with NHS side colleagues and PKC colleagues have indicated that we won't move to a proportionate basis for year 3, that it will be on an actual basis aligned with budget. The external auditors have picked up the fact that we haven't got formal agreement to that, and we'll be seeking to have that discussion. And that's what, when certainly for year 3 there'll need to be a final agreement between parent bodies that is what we're doing. In some ways it comes back to the point Alistair made earlier. If we were moving to have integrated budgets at a faster pace, that's really why the proportionate approach sits there as what we're expected to move to, where the definition between health and social care budgets is lost and therefore the only way in which to share an overspend, because you lose the definition of services, is on a proportionate basis. As we have talked about already this morning, we are not at that place yet. It's still, we are able to talk about health services and social care services, and only around the margins are we talking about integrated services. So as we move forward and there starts to be a blurring of services and true integration, I am guessing that's when the parent bodies will want to have a serious discussion about proportionate budgets. In the meantime, what we can do in the partnership is set up the discussions, formalise the position for 18-19, which we absolutely rightly have been asked to do by our auditors, but set up the discussions about, you know, what happens thereafter, because the integration scheme talks about may move to a proportionate basis for year 3 and beyond. So it's absolutely up for discussion for both parent bodies to decide for year 3, but thereafter when and if we move to a proportionate basis.
And in terms of the governance around the risk-sharing arrangements, is that just agreed between the chief executives of those two bodies and the chief officer, or does that have to come to the IJB for approval?
So I have a commitment to speak to the two chief executives and to bring this conversation forward. And I think we'll be able to determine where it goes thereafter once we've had that conversation. But that conversation is imminent.
It doesn't have to come back to the IJB for. I'm given that obviously it's a strategic decision, I suppose, as well, about how we're viewing health and social care integration in terms of whether we're looking at proportionate basis or not. But certainly for the future.
Yeah. It would seem logical that it would come back to the IJB for its approval.
Thank you.
Okay, Dr. Pete was next, or did you want to come in on that point, Mr.
More specific, so perhaps Mr. Brown.
I just want to bring clarity to that point. It's in the legislation, the arrangement. The integration scheme introduced for the first 2 years a different approach. The decision on whether that different approach carries forward rests with the Council and the Health Board, not with the IJB.
Okay, thank you for the clarification, Mr. Brown.
And it would have to go to the Health board rather than the Chief Executive for agreement. I would suspect it would be the same in the Council.
Okay.
But that's for the Council to decide.
Thank you. Dr. Pete.
Thank you very much. I appreciate the explanations that have been given so far. My question is perhaps a bit more specific in relation to social care budget, a significant underspend to the end of last year, and I suppose very quickly fairly significant overspend, and particularly in areas of, as has been explained, learning disabilities, mental health, residential placements. I just wonder if that's unusual in terms of not being anticipated this year, and there are other particular reasons. Is it about ways of working and so on, or is something very specific happened that has caused such a significant overspend?
Okay, could I bring in Diane Fraser, the Head of Adult Social Work and Social Care, and if she would like to contribute, Jackie Pepper, our Chief Social Work Officer. Diane?
Thank you. It has been an unexpected demand that we weren't able to project. We have had in the past a very good system around identifying young people through our transition arrangements, and that seems to be working very well, but we have had unexpected demand from a number of individuals. It's not a significant number, it's a small number, but they're very costly care packages due to changes in people's circumstances, their progressive illnesses and conditions, and specifically very challenging behaviour.
Okay. Does that address your question, Dr. Pete? I thought I saw a hand over here. No, did I not? I'll bring in Professor Beach next, I think.
Thank you very much. This is a question that I think accompanies one of the earlier points, which was about total funding. My question is a little bit different, and it might relate to my relative ignorance as a new member of the board. And it's really around discretionary spend, or the amount of discretion that the group actually has. I'm reading into these figures, and I guess that the other subcommittees will know more about this than I do, that there are quite a few areas over which there is relatively low levels of control by the board itself. So, for example, on staffing, I imagine that people are subject to national negotiations, that there will be on-costs related to pension payments and so on, that actually can't be changed. So we don't have an ability to move very much in those areas. That some of the savings that have occurred have been through vacancies and I guess through staff turnover. I'm not aware of the level of turnover as against benchmark. Is it something that is very high or very low? Does it relate to particular professions? We heard earlier comments particularly about nursing, and I'm not sure whether that would be a particular area of concern and what might be done there. So part of my question is, to what extent have we got discretionary control over expenditure and indeed income generation, and how does that level of discretion relate to the overall size of the problem that we've got? And I ask that question because if we've got, let's say, a value of 10 in discretion, but we've got a problem, let's say, of 100, then however good we are with the 10, it's never going to be 100. It will always leave at best 90 of a problem. So I've got that first question, which is how much discretion have we got? And you might not be able to answer that immediately, but it would be helpful, I think, certainly for me to understand that better going forward. The second point is, how does that change over time? Because a lot of what you've been talking about, I think, relates to longer term or mid and longer term transformation, where you can look at service change delivery and then having the right leadership to change that. And I noted in what you said, Keith Matthews was one of the people that had been appointed to help with that. And I think, I'd just like to say, I think that's an excellent appointment, knowing quite a bit about the work that he's been doing. So that's one of the things I think might give us confidence in facing some of the risks that we've got.
Mrs. Smith?
If I can come firstly to the issue of discretionary spend, at a strategic level, the summary I would give is that across our roughly £200 million budget, there are a number of areas where we have almost no discretion. I would highlight those as being within family health services, the contractual payments that we make to our family health service contractors, our GPs, our pharmacists, our dentists and our opticians. It's a big part of our budget, but it's driven by detailed contractual negotiations at Scottish Government level. And so we've got a big budget there, but very little discretion, if any, on how that's spent and reducing those costs. GP prescribing is a really interesting one because our GP prescribing, our GPs are self-employed, and therefore it's not within our gift to tell our GPs how to prescribe. And the key to that is about our relationships with our GPs, engaging with our GPs and them working with us to manage the GP prescribing issues and our wider partnership issues. And we've invested some significant non-recurring money to make sure the strength of our engagement with our GPs sits at the heart of the partnership. Another area that's not directly within our control is our large hospital set-aside budget, where we are required to work very closely with our acute services colleagues, and I think there's a long way to go to establish the true joint working arrangements that are required to understand how we shift the balance from our acute medical beds and shift the balance. So that's we have a joint responsibility for those budgets for strategic planning, but we don't operationally manage them. Within social care services, we have a number of what are described as statutory services. A significant element of the services that we still provide would fall into that category, and I think it's fair to say that in terms of the level of discretionary provision within social care, we have reduced that over the last few years. Therefore, what we've got left in terms of areas of discretionary spend are relatively small. That's not to say that across those budgets there isn't opportunity to bring about transformation, but it has to be transformation within the context of our statutory obligations.
Mr. Packham.
Thanks. Thank you, Professor Beach, for your question. I mean, I'm going to just maybe talk a little bit about the changing over time rather than the things that Jane has talked about. There's a significant challenge in terms of changing culture and changing the ways in which people operate. Within the new primary care contract, there is an opportunity to bring another range of professionals and services around the GP to allow the GP to become the expert generalist. This is essentially a skill mix exercise in primary care. And in time, I would expect that it will spread the workload and change the first point of contact for many people. And similarly, when we look at our mental health services, earlier we talked about the number of people who are in PRI that potentially could be managed another way. From Professor Matthews' early work, we are pretty convinced that there are opportunities to revisit how things are going to be delivered in the future. And key to that is our work with the third sector, the independent sector, and how we're going to look at all of the anticipation, early intervention, prevention work that we know is happening in spade loads. But what is not happening as well as it could be done is that connection between the services for mentally ill people and people with an established complex acute problem in a learning disability, and then all of the things that help them to function well in their own communities. So there's a beginning of a large conversation around how that redesign will come. So it's going to take time, but it's absolutely on the way.
Mr. Brown? Thanks for that. I'd just like to reflect firstly what Jane said, and then I'd like to go back to Councillor Drysdale's earlier points, if I may. The point around the set-aside budget, the budget for unscheduled care, and the fact that the IGB doesn't have control of that, and the management and accounting for that is within the health board. I suppose, I don't know if it's an upside of this or not, but the upside of that means that the health board is actually carrying the overspend in that budget, and that overspend is predominantly driven by unnecessary demand and driven by delayed discharges. And if you cost the delayed discharges at the Scottish Government's figure per day, the health board's probably carrying about £7 million of its current overspend is in that space. So whilst the IJB has the means to resolve these issues, the cost of it not being resolved is actually sitting with the health board currently. Within the legislation, there is the facility to go to the IJB, to look for the IJB to pick that up, and the health board hasn't gone down that route. And I suspect these are all part of the discussions that Jane will be having, as she said earlier, around this mid-year point of how we get to the end of it. And again, I would assume within that discussion we'll be talking about the 1.2 million reserves for social care that were held over last year. So this position is far from clear at this point of time, and that's not good. And that takes me to Councillor Drysdale's point. We recognise that we do not have as good financial information as we should have. We also don't have as good performance information as we should have. And there's two large pieces of work being undertaken within the health board to deliver on that. And that improvement in financial information, the improvement in performance information will include those services that the IJB is responsible for, and will include the IJB budgets. So my expectation is quite clear that we will get quickly to a point where we do have much more transparency about what things are costing us and what the cost drivers are in it and what the impact and performance is. Also, just to give you a bit of reassurance around the passing on to the HSCP of the funds for the services the HSCP has to deliver. The health board does and will continue to pass on to the HSCP and therefore the IJB whatever we're allocated by the government for those services. There's no question of them not doing that. The impact of not being in financial balance in the health board, as Councillor Drysdale touched on, will result in us requiring brokerage. I've got no doubt about that, certainly for this year. I've also got no doubt that the government will support that. The government will support that because we will have by then a very clear financial forecast which will give the government the confidence that we've put the steps in place to get the board back into financial balance, and it'll give them a much clearer timescale for that. So this is all the work that's in progress with the health board at the moment to get us back on an even keel. But we are not unaware of the difficulties that HSCP has, and we're very much working towards bringing all these things together, because you cannot, as Dr. Noble said, you cannot manage this separately in chimneys. This has to be managed on an end-to-end basis. Just one final point, if I might. GPs prescribing, independent contractors. GPs do have to prescribe according to Scottish Government policy. They do have their professional bodies. So certainly it's not for, I think, any of us to tell any clinician what they should be prescribing. I do think that there is a degree of scope for looking at GP prescribing and bringing that into line with the expectations that the policy is, and the expectations of the professional bodies. There are certainly some outliers.
Thanks, Mr. Brown. Dr. Noble, you wanted to come in?
Firstly, just to echo what Mr. Brown's just said, and just to cheer you up a bit, we've got 6.4 million occupied bed days in Scotland. 600,000 of these are delayed discharges. That's 2 district general hospitals full, so we really need to do something about that. But then we get into what I regard as the key to all this, is that Perth and Kinross has already got an excellent data set. We've got fantastic information. And for example, 2% of the patients occupy 79% of the occupied bed days, and 2.5% of the total population are 50% of the spend. And you've all seen before these top 10 health and social care things. Now, I think if we start concentrating on that small number of patients who are very high cost, it'd be very interesting to see just how value for money it is and how much money could be moved. And I can't think of any other organisation that would allow a default position of an occupied bed day in its most expensive kind of care provision as being the sensible way forward. I've always argued this, that if the responsibility, the accountability must go to the localities. And for example, around GP prescribing, there are really good indicators from historic work that the GPs don't like to be out of line on their prescribing. And if you start comparing what they're spending with the next locality and the next locality, things will change and can change. And the point that Mr. Brown's already made is there a stack of evidence from Perth and Kinross and from the west of Scotland stuff, from Hill and Dublin stuff, that we are over-indulging the worried well and not using all our money wisely, and that's realistic medicine. So there's a lot of good things going on, and I think it would be well worthwhile revisiting some of your previous data and looking at how you can prioritise making sure that everybody has value for money and trying to get a handle on these very expensive patients and whether they in fact are value for money in the sense of what we're all talking about, because we're going to have to stay within a fixed budget, whatever that fixed budget is in the future.
Okay, thank you, Dr. Noble. Do you want to come in, Dr. Dougal?
Yeah, I would just pick up the point you've made, Alistair, about variance and just looking at locality budgets and GPs not liking to be out of step. We do that already. They get a quarterly report that compares them to every other practice, and we're looking increasingly within P&K at how we can bring variance to the attention of individual practitioners. So, yeah, I would fully support that.
Thank you. Councillor Drysdale.
Yeah, thank you. I'd just like to come back after the comments from the gentleman to my right, Mr. Brown and Professor Beach. And firstly, I'm delighted to hear the progress that is anticipated to be made in the financial information coming forward from NHST side, and that will clearly help. But if I understood Jane's response to Professor Beach's substantive question around the degree of discretion that we have going forward here, you've described the level of discretion in all of the services, and there's not much in any of them. It therefore means that if we are looking forward for 1920 budget, which we're about to start tackling in earnest. The difficulty we have is that if we're looking to address the savings requirement of 7 or 8 million, and the level of discretion is 10 out of the 100, then that's a hell of a percentage of the discretionary items that are going to be under threat as we look at future year budgets. And so it's imperative that we do have full information just as soon as possible. And again, I'm afraid I do come back to the point that this level of financial pressure and this level of threat to not just discretionary services but statutory services must be a worry for both bodies and must be addressed as part of the upcoming budget process.
Okay, thank you. Have we got any other questions or comments? No. Okay, can we note the 2018-19 financial position and year-end forecast and move on then? Yep. Okay, thank you very much. So we'll move on to the next item on the agenda, which is item 3.3, the minute of the meeting of the board of the 22nd of June 2018. And just as we do that, I'd like to note that Councillor Purvis is being substituted by Councillor Jarvis for the remainder of the meeting due to prior engagement. Are there any questions or points on the minutes of the 22nd of June meeting, or can we agree those minutes? Agreed. Thank you very much. Item 3.4 is an action points update from that meeting. From all of the previous meetings. So we've got the action points updates in front of us. Are there any particular points that anybody would like to pull out? There were a number of items, I think, which were due to be either at June or today, and these are covered at various points in the agenda. But if anybody spotted any particular questions? No? Okay. We'll move on then to the item 3.6 on the agenda, which is a report on the an update on the board membership. And I'll, in a second, hand over to the clerk to the board, but it was remiss of me at the very start not to welcome to their first full meeting as members Professor Beach and Dr. Pete as new members of the Integration Joint Board, appointed as non-exec members of NHS Tayside. And, I beg your pardon, also Claire Gallagher from Independent Advocacy, Perth and Kinross, so welcome all of you. Mrs. Taylor, would you like to speak to the report on the board membership update?
Thank you, Chair. It's a complex picture, but hopefully the report sets it out reasonably straightforward. As the Chair mentioned at the start of the meeting, following the resignation of Stephen Hay, we do now have a further vacancy from our NHS Tayside colleagues, and I believe that will be considered together with the nomination for a chair of the board at the next meeting of the board at the end of October. Also have an apology to Claire Gallagher for billing her in the appendix to the report as being from PCAFs, which she's not. She's from Independent Advocacy, Perth and Kinross, so apologies for that. Welcome to the board, along with Sandy Watts as her substitute. In relation to the service user representatives position, We have had that clarified, that Linda Lenny and Sandra Auld, the request is for the board to approve an extension to their appointment to October 2020. The next recommendation is with regard to Dr. Drew Walker and Dr. Alistair Noble to extend their appointment until the 31st of March. I think with the new strategic plan coming forward and the 4 work themes, I think in terms of good governance, it's opportune for the board to actually undertake a skills matrix to make sure that we have the right people around the table, and obviously the order allows for the board to appoint additional people to make sure that it has the right expertise and knowledge and experience. With regard to the last recommendation with regard to a voting member from NHST side to fill the vacancy on the Audit and Performance Committee, and I understand that Professor Nick Beach has agreed to take on that role. So happy if the board could agree all those recommendations. Thank you, Chair.
Thank you, Mrs. Taylor. Are there any questions or comments on that, or can we, Mr. Brown?
Just to provide the IGB with an update on the position, as far as the changes to the NHS membership of the IGB, I've asked Dr. Pate to take over from Stephen Hay as the chair, and Gillian Costello, the nurse director, will join the IGB as a full member. So we've actually had that discussion with the board, and it'll be formally ratified at our board meeting in October.
Thank you, Mr. Brown. Any other, Mrs. Lenny?
Okay, this is just for accuracy for the paper at 2.2. That should actually read that Linda Lenny was elected as service user IGB public partner and Sandra Auld was appointed as a substitute, and that Bernie Campbell was reappointed as carer IGB public partner and Maureen Summers as a substitute. Thank you.
Thank you for bringing that to our attention. That's noted. Can we agree the recommendations as outlined by the clerk? Yep. Agreed? Yes. Okay. The next item then is the appointment of a data protection officer. This is 3.7 on the agenda. Board members will be aware that the implementation of the EU General Data Protection Regulation, or GDPR, came into effect on the 25th of May. 2018, it introduces a new requirement for organisations to appoint a data protection officer who will advise senior management and the board on matters of compliance and monitor and report on compliance to senior management and liaise with the Information Commissioner's Office. And we are asked to agree that Donald Henderson, Perth and Kinross Council's data protection officer, be appointed also as data protection officer for the Integration Joint Board. Is that acceptable to the board? Yep, great, thank you very much. 3.8 is the Audit and Performance Committee, but we took that earlier in the agenda. So 3.9 is an update on standing orders. There's a copy of the standing orders in your document pack, and what the final standing order, if I'm correct? Yeah. So standing order 19 is about a review of standing orders, so it requires us to review the standing orders on an annual basis. That review has begun. We have identified a couple of inconsistencies between the standing orders and the integration joint scheme, and we also want to make a note following our earlier agreement to record meetings of the Audit and Performance Committee, that the audit and that will require a change to the standing orders. Oh, sorry.
Chair,
Gillian.
for clarity, the revised standing orders which are before the board, say proceedings of meetings of the board, committees or subcommittees will be recorded. So we've covered the Audit and Performance Committee.
Would you like to outline any further changes, Mrs. Taylor?
I think the only other change, this is part of the annual review, as the Chair has said. The only other point that I would want to make is that in 3.2, the previous, with regard to the rotation of the Chair, there was an inconsistency between what's in the scheme and what's in our own standing orders, so that's being amended to be consistent with the scheme. Clearly, as the Chair of the Audit and Performance Committee indicated during his earlier discussion, if there are other changes to standing orders that need to be made following discussion about the remit of the Audit and Performance Committee or the future arrangements in relation to clinical care and the professional governance, then those will be reflected in further changes to the standing orders that be brought before the board.
Thank you, Mrs. Taylor. So it's our proposal, I think, that those changes that we've outlined be incorporated so far. We do need to have a further discussion about the clinical care governance matters, and we also need, I think, to have a discussion about reporting of complaints and the appropriate committee to do committee, or whether that goes to a committee or to the board appropriately. My suggestion to the board is that we invite you all to pass back any further comments on the standing orders to, in the first instance, probably Gillian Taylor and Scott Hendry, and bring back a full revised set to the next meeting. Is that?
Thank you, Chair. If there are any further comments, that we would obviously be very happy to take those on board. I think it's probably helpful just to clarify that standing orders are primarily about how the board runs its business in the board meetings, in relation to where complaints might be reported. That's really more a matter for a complaints procedure. So I think we just need to make sure we've got that distinction about what the standing orders are for. But certainly in relation to the role of audit and performance and clinical care and professional governance, I think it would be useful if that information formed part of the standing orders.
Okay, so is that Councillor McEwen.
I would actually like you to consider looking at Standing Order 2.12, which refers to the proxy members of the board, which obviously I'm one of the proxy members. And the statement that's in there just now says that I'm not allowed to attend meetings unless as a substitute. I'd like to get the board to actually have a look at whether proxy members would be able to still attend meetings and ask questions, but obviously not be allowed to vote, because that wouldn't fit in with the voting structure, but to still be able to positively engage with the committee on a regular basis. I think one of the difficulties proxy members have in dipping in and out of the committee is continuity and be able to understand what's gone before. And I think having a statement in there that says we cannot attend meetings other than sitting in the public gallery maybe isn't conducive with a constructive, positive approach going forward. So I'd just like the board to consider that.
Okay, thanks, Councillor McEwen. I note that we have got some of the public partner, or one of the public partner alternates in the meeting. Certainly, in the past, I know that some of the councillor representatives have attended as proxies in order to get an idea of the business of the meeting. I think it would be appropriate for people, for maybe us to amend the standing orders so that clearly your attendance is not precluded. But we should just keep it to, if we've got a set number of members and a set number of voting members represented, if we keep the actual business of the meeting to those ones that are nominated. But we can maybe just make a slight, take on board that slight change in the wording, Mrs. Taylor?
I think the intention of the standing order is more around participation than actual attendance. And clearly, proxy members would be entitled to be present at the meetings but not to be sitting at the table and participating, because there are a set number of members. So if you were here and your substantive member was here, you wouldn't be entitled to participate, but certainly you're entitled to attend but not to participate. So I can look at changing that wording to clarify that.
Okay, thank you. So if that's acceptable without any further questions or comments, as I said, any further suggestions for revisions, if you pass them back to Mr. Hendry and Mrs. Taylor, and we'll bring back a new set to the next meeting. Right, so we'll move on now to item 4 on the agenda. Mr. Packham, as Chief Officer, is going to provide us his strategic update. Mr. Packham.
Thank you, Chair. First of all, may I add my thanks to Stephen Hay, in his previous role as chair. We are indebted to him for his commitment to the board and for the contributions that he made. I'd also like to add my welcome to the new members of the board and thank you for their support. Your support. In my report today, I have detailed 4 topics, but there are a couple of additional things I'd like to add informally at the end. And so first of all, looking at the refresh of the strategic commissioning plan, there's been a lot of work going on in recent weeks now to define how we will determine the shape of services to come. We've heard Dr. Noble speaking this morning about the importance of working in localities. However, when you talk about working in localities, it doesn't help you to get into the detail of how clinical and care services will change. So we've defined, as you'll see over the page, 4 new care streams: older people in unscheduled care, and that will take care also of people with physical disability, mental health and well-being services, and that will include substance misuse, etc. The support to carers, which is an extremely important part of our future as we seek under the Carers Act to support the needs of carers and to assess their needs and to take that fully into consideration as we consider the delivery of care in the future. And then finally, the primary care work stream will help us implement the new GMS contract and look at how primary care services will in future provide that expert generalist service that will support people to stay at home. Now, underpinning all of that, we have a corporate support function, which is really about bringing the health and local authority support services together. So we're already beginning to discuss how we look at, say, our performance data and bringing the teams together who support that. We have an increasing opportunity to bring finance and HR functions closer together, and in our meetings we are considering how we work in partnership with our staff associations as well. So in the corporate support work stream, we'll be looking at how that can be made most efficient and how the roles of the people who are supporting all of our functions can be brought together. Earlier in the meeting we talked about the possibility of the joint working agreement, which will be in place by the end of this calendar year. This brings us the opportunity to make sure that people who are operating as leaders have the ability to work across the organizations and remain within the appropriate policies of the employer. At the moment, we have to have a supervisory system that takes us up the employer line, but in future this joint working agreement will put us in a place where we can create far more flexible solutions for the future. So in terms of the programs of care, we will have a strategic planning board that will oversee these work streams. They will need to make sure that the balance is right between all 4 of the streams that have been described, and they will also help to steer some of the work of these 4 care streams. So there'll be an element of future direction set by the strategic plan, which is in refresh at the moment, but also from the ground up, local action partnerships will bring ideas forward, staff groups will bring ideas forward, and they will be streamed as has been described. I'll just pause at that point, and if there are any questions on the programs of care, I'd be delighted to answer any questions.
Any questions or comments?
Mr. Brown.
Mr. Brown. Thanks very much for that, Rob. Just a couple of quick questions from me. On your primary care programme, am I right to assume that that is part of the Transforming Tayside programme? It's not a separate piece of work from the piece of work that the board heard of yesterday at our development session?
Yeah.
Thank you for that. And in the same sort of vein, the work on mental health and well-being, can I have the assurance around how that is feeding into the independent review of the mental health services across Tayside?
So at the moment, Mr. Brown, I mean, we have a plan to bring together health and care services around the community. Something like 96% of all mental health care is actually delivered in the communities. So this is about making sure that our strategic planning and our thinking for the future and the new models of care will be coherent and carefully considered across all of the different elements. In terms of its direct connection to the current independent inquiry, there isn't an overt connection, but there will be in terms of the fact that the services that will be subject to the independent inquiry are contained within this area. So therefore, people who are working in this area will be obviously open to the inquiry itself and to participate in that as they're requested to do so.
Can I suggest
Yep.
that it would be worth considering contact with independent inquiry and ensuring that as your thinking's developing, that they're kept up to speed as to what changes are in the pipeline.
Yeah.
And also so that the other side of the coin, as independent inquiry finds things that need to be done differently, that you're able to factor that into your thinking there. I think it's very important that the work of this inquiry lands within the health and social care environment. My final question on this is around corporate support. Clearly this is not a big organisation, the HSCP. We are struggling financially, so anything we can do to cut our management overheads or our corporate overheads. Has there been any consideration done to sharing some of these corporate support services with the other two HSCPs in Tayside, or having the health board or the council provide some of them for you?
So I'm going to ask Jane to answer your question, Mr. Brown, because Jane is going to be the lead in this area.
Okay, the priority for us in the partnership at the moment, I mean, as you'll be aware, the corporate support arrangements that we rely on are about receiving corporate support from both NHS Tayside and Perth and Kinross Council. So if I take the example of the finance support that we receive as a partnership, I'm relying on that which NHS Tayside team provide to me and the council team. Now, as we move forward and we look at new models of care that transcend the current silos that we've been talking about earlier, having two finance teams in different locations is not conducive to the work of the partnership. So my priority for finance, as an example, is not about spreading the finance team into the other IJBs. It's providing an integrated finance function for us here in the partnership and driving out the efficiency that comes from doing so. And that might also apply to other corporate support functions such as project and programme management, our approach to performance management, where we're looking at the separate provision that's existed up until now, how we bring that together, how we provide integrated support to this partnership, and how we deliver the efficiencies from that.
And would you be able to give us some assurance then that you'd be doing that at no cost, no additional cost?
No, I couldn't at this stage, and I'm in detailed discussions with colleagues in NHS Tayside on one hand and Perth and Kinross Council on another, where the level of financial capacity is subject to discussion, and making sure that may be about redistribution, across Tayside to make sure that the partnerships are supported, and similarly within the council it may be about redistribution within the council finance team to make sure the finance team supporting the partnership are supported. So it may mean an increase in overall resources to us, but I accept that it needs to be trying to maintain resources overall. However, you know, the risk that we face in terms of the level of transformation that we've been asked to deliver, strong finance business partner level support is absolutely essential, and we have not got the requisite capacity at this stage, so we need to look at all possible ways within existing resources if possible to get that in place.
I suppose my concern is that there is no additional funding being put into the health and social care system, either to the council or to the health board, to support an increase in corporate support. So if we're going to have to increase corporate support, then it has to be taken out of service, and I would be very mindful about doing that. So I would hope that these proposals would be coming to the IJB to give careful consideration to any increase in the size of the corporate support around the health and social care partnership. If the current model of it being provided by the two organisations is inefficient, then we should find the efficiencies. It should actually be a saving.
Which is absolutely what I've described. That would be the absolute intent, to bring the teams together to understand the efficiencies that can be driven out where it's possible to do so, but where there is an underlying lack of capacity, that's something we would both want to bring to the IGB, but we want to discuss with both parent bodies.
I mean, if we can take efficiencies out of corporate support, that's definitely preferable to actually cutting services.
Yeah. Okay. So if I could move forward, I was going to discuss alongside the programmes of care the connection to the Transforming Tayside programme. So very recently, Anne Erickson, I referred to earlier, has been brought in to lead this strategic programme of work. And it's very clear that the strategic plans of the 3 IJBs must connect effectively with the plans for acute care. So we're already building bridges with Anne and asking her to be involved in the work that's local here to Perth and Kinross. And also we're making sure that the Transforming Tayside plans are aware of the work that's going on here. There are wider partnerships as well. Clearly, we're considering the continuity of care between children and young people's services and the adult services for which we are responsible. And clearly, we're wanting to make sure that as we work in the future with other partners such as police and fire and the prison service and so forth, that we have the adequate connections to make sure that shared agendas are discussed. So already I have somebody beginning to look at the potential for us to work more closely across the criminal justice service and ourselves within the health service, particularly with a focus on mental health, drugs and alcohol services and learning disabilities. Okay, so moving on now to talk a little bit about the preparations for the joint inspection. At roughly midday, just after, we're going to be doing a presentation and a development session for members. Perth and Kinross Health and Social Care Partnership is anticipating that in the early part of 2019 there will be a joint inspection from the Care Inspectorate and Health Improvement Scotland. We've already started our preparation work, and we have a self-assessment in progress and in development at the moment. It's just recently been out for comment with Critical Friends, and that comment was returned to us by Wednesday of this week. You'll see in the paper that there are themes to that overall assessment, and it'll be looking at our journey so far. It's not looking at the future, our aspirations. It's very much looking at what have we achieved to date. So it'll be looking back at the development of the partnership and in the first 2 years of practice. Perhaps a focus on outcomes is where we should consider this, because this is not just about the inspection. This is about a real change, a benefit, about improvement in the ways in which we operate. So far, we have been speaking to our own staff. We've had 2 of 6 presentations going out across the partnership. There was a presentation recently to the executive of Perth and Kinross Council, and on the 11th of October, we'll be presenting a similar presentation to the executive team in NHS Tayside. There is an opportunity for any other bodies who would like to hear about this inspection in more detail to approach us, and we can do our best to come and tell you more about it. We're expecting the inspectors will come in for a week, they'll be away for a week, and they'll come back in for another week. And they will be attending meetings, they will be working with our partners for them to feed into this process and to help make their assessment. Again, can I just pause for a moment if there are any questions about the joint inspection?
Just before you started that last bit, Dr. Noble had a question, sorry.
Sorry.
Dr. Noble.
Sorry, and just for memory, I started with the multi-agency inspection for services for older people in Tayside, so it's a well-trodden road, and I think it's a very useful time. Can I just go back to this whole thing about some of the other issues, and can echo what Mr. Brown said about from a community empowerment and sort of aligned planning process, and how important it is that the localities are held accountable and responsible, because unless we get that local accountability and responsibility, we're not going to get rid of that variation that we've touched on already. And remember, in all this, when we're talking about data, it's at that level the individual patient becomes known to the organisation as an actual something that can be done about it. And in terms of my understanding, we're moving towards prioritising community teams and making sure each community has its correct team, and that's as close to a fixed cost as we can get. And the buzzword, which I've just picked up, seems to be about locality economy and that wider issue of linking all things, not just health and social care, but education and housing and all these things. So just to to be very careful we don't get too into the medical or the social work model. We're looking at the wider issues that each community would identify with. And to echo the point that's been made clearly here, we're talking here about a rationalisation of total resources and an integration of backroom staff. And that, all that must be driven by making sure that the individual patient gets what is appropriate care. But that might be different from the appropriate care they're getting at the present moment, and we all have to address that in a very realistic way.
Okay, thank you, Dr. Noble. I actually had my own question on this, but so on the programmes of care, Rob, it was really just to check how we'll know that we're on track with each of those. What under each of the themes, what sort of results there are that we want to achieve, and understanding that would help us define the actions within each of those programmes. But how will we define those, and when will we define those?
One of the things that we're working on for the IJB is a forward plan in terms of when reports on each of the programmes of care will come forward. That is something that Stephen Hay asked for in his previous role, and that we're currently working on. And an absolutely key component part of that plan will be when we can bring forward strategic delivery plans for each of our care programmes. The one which is probably most advanced is our strategic delivery plan, Older People in Unscheduled Care. We would hope that that would come forward, at least an update in this calendar year. Alongside that will be a performance framework to support that, where we set out the performance measures against which we will measure our progress. So what we should be able to bring forward to the next meeting, programme by programme, is a reporting proposal in terms of what comes back to the board to provide that reassurance of progress and how we're measuring it, along with some specific reports on older people in unscheduled care, specifically in the early stage, with the others following very close behind.
Okay, thank you very much. Mrs. Campbell.
Thank you. Sorry, it was just a request that the public partners, if they could be involved in the joint inspection process, as we have not been to date, if that's okay.
Of course.
And presumably it will be the views of service users and carers from, yes.
Yes, thank you for your question. At the stage of our current development, all we're doing is bringing together a range of evidence to prepare the inspectors for their visit, to give them the background information that will be sufficient to help them target their activities when they come to visit. We would expect that they will have a direct contact with everybody who's a stakeholder in the partnership, because the strategic intentions of the inspection are very much around making sure that we have improved outcomes for people.
Okay, thank you. Mr. Brown.
Thank you. Dr. Noble's prompted me to go back to the commissioning plan and the process, the sequence of events, and prompted me to think about the consultation and whether the 4-week consultation process is enough for us to be confident as an IJB that we have heard the voice of the community, that we've had that local input. That's at one level. And at the other level, the timing of it, as we discussed at the last health board meeting, the IJB strategic plan has to be developed with input from the key partners, including the health board. The IJB, it actually says in the legislation, has to take into account the views of these partners. Now, the health board meeting's in February. If you're bringing the draft strategic plan to us at that point, then it's going to be too late for you actually to meet your deadline if there's any changes that then have to come back to the IJB.
Okay.
Yeah. So I think that process of consultation, not just with the health board and the council, which is obviously very important, but with the localities, might be something you want to take another look at.
Okay, thank you very much indeed. We'll do that.
Okay, any other questions? So, programmes of care and preparations for the joint inspection.
you want to go on and talk about the mental health
Okay, so
aspects,
this thank you very much. This is just to update colleagues on the time scales for the moves as they're planned at the moment. And also one of the key themes that was discussed at our last meeting was the concerns about transport. Forgive me, I'm just going to kill this. And you'll see detailed there some of the work that's going to be undertaken over the coming months. And you'll see highlighted in each of the boxes on page 126 where there are transport implications to be considered. And then in 4.2, I'm talking about the way in which we're approaching transport. And clearly for some people, travel will be unaffected, but then for others, it very much will be affected. So I have been working with colleagues both in the NHS and here in Perth and Kinross Council to make sure that the needs of people whose services will be moved in location are considered. And I'm going to invite Gillian Taylor just to talk a little bit about what's going on here locally in the TAC-TRAN.
Thank you, Rob.
Okay.
Wearing one of my other hats, I'm still currently clerk to the Tayside and Central Scotland Regional Transport Partnership, which is more handily known as TAC-TRAN. And they have recently been doing a lot of work with colleagues in NHS Tayside and NHS Forth Valley in terms of mapping journeys, patient journeys and visitor journeys to and from health facilities in NHS Tayside and NHS Forth Valley. And we just learned about this at a meeting I was at on Tuesday, so I thought it would be useful for the Health and Social Care Partnership to perhaps tie in with some of that work and see if that was helpful in terms of the discussions around transport.
Finally on this, just in the last bullet point at 4.2, it's to bring together the work that's being done on the wider redesign of services in NHS Tayside alongside those which we've discussed for mental health. And the head of improvement in NHS Tayside is coordinating the approach across the changes in locations for the NHS's hospital services and creating a focus on transport. We also have with us today Mr. Bill Nichol, who is leading on the independent inquiry preparations and also the BBC programme, and he discussed with the board last time some of the preparations. And then I've already covered the leadership issues around Professor Keith Matthews' new appointment and the fact that we had Dr. Kaplan in for a while and he will be leaving us at the end of this month. We've had recommendations for changes in the training program for junior doctors, and there's an action plan that's detailed around that, which is currently being enacted. And then most recently, we've been looking at the number of risks that have been identified across mental health services. In Tayside, we did a mapping exercise recently looking back over a series of years and looking for the common themes and to make sure that the actions that are being undertaken in the transformation programme are taking cognizance of all of the recommendations that have come forward to date. And then finally, the Mental Welfare Commission is obviously looking to ensure that the rights for advocacy are properly thought through and planned within each of their areas of interest. And a further update around the Mental Welfare Commission's issues on rights to advocacy will be brought to a further board meeting. There were two, unless there are any comments or questions on that, I can pause, and there are two or three other things I could mention.
Yeah, thanks, Rob. I think it's also worth noting just in terms of the issues around the independent inquiry and the documentary about Carsview that Mr. Hayes and my initiative shortly after the documentary aired. Some of the members around here were invited in. We had an extra board meeting, if you like, where we got to explore some of the issues, and following on from that we also got the opportunity to tour around the Carsview Centre and to talk directly to people there and ask questions of the staff in order to try and gain a degree of assurance that the issues that were being aired at the time were being properly dealt with. There was a question there from Mr. Drummond.
Thanks for that, Chair. My first point is under 4.1, where we say the first day moves will start obviously in September, being obviously like now. Can I just bring that to the fore, the fact that the time frame I think is unrealistic. We have to give the patients and carers 28 days notice. We haven't done that, so we know even now if we're to give them notice today, it would be the end of October. So we haven't done that, so I think the time frame is unrealistic. Also looking at Mulberry unit from Stracathro Susan Carnegie Centre relocating to Carsview. We know that throughout the one-to-one process, we've moved the staff out of contingency through organisational change, and that the staff have said they're unable to sustain that. So therefore 80% of the staff are unable to move with the patients. So just to flag the risk that we think that there'll not be the staff to deliver the services that the patients have got in the current contingency arrangement. So my concern is that. And obviously the transport's been implicated. There are issues with transport. You've got staff who have vehicles on PCP, for example, whereby they've capped mileage on their vehicles. We feel it's unfair for the staff to be asked to drive additional miles, whereby they lived in Angus and worked in Angus, and they're being relocated to Dundee. So we think it's unrealistic to ask the staff to do that. And also the fact that at this moment in time, we have transport and time provided by the employer. Therefore, that will be removed because the committed contingency into organisational change.
Thank you, Alan. Sorry, I'll note your comments, and obviously I'll take them back to the team that are running the programme of work. Clearly, the timescales are slipping, and there will be modifications to this plan, I'm sure, as we go into this. In real time, there are a team of people who are looking at this and considering carefully the implications for individual staff. Now, our most important priority is to make sure that care is safe and effective. And so we will be bearing in mind all of the staffing issues that need to be considered, whether it be about the availability of staff or their ability to travel, etc., and factoring that into the change programme. So we've already seen that this is quite a complicated process for individuals who may, for very personal reasons, not be able to sustain the travel between the north of Angus and Dundee, and similarly between the sites in Dundee and Perth. So this is being taken into consideration, and the one-to-ones, having nearly concluded, I think now, are very important in terms of setting that direction and helping us to understand the workforce implications of change. We were not able to see that until the point that everybody had had the opportunity to have that discussion about their own personal circumstances, but now we have a clearer view.
Thanks, Rob. Ms. Lenny.
It's in connection to 4.4, the BBC programme on Carsview Centre. So you mentioned in there that you've got support for the staff, but there's nothing around support for service users. And I don't know if maybe I'm missing the point, but if there's like changes to any organisation that would impact on people who use the service as well.
Thank you, Linda. I'm going to ask Mr. Bill Nicol to make a comment on the progress that's been made so far. Bill has been given responsibility by the chairman and by the chief executive to coordinate this work, and it is somewhat separate from the work that we are managing operationally. So if you don't mind, I'll ask Bill to answer.
Yeah, thanks, Rob. The chairman, NHS Tayside board chairman, announced at the time of the broadcast of the documentary the way that NHS Tayside would respond to that, and really called for a significant assessment of all of the data and evidence to triangulate some of the issues and allegations that were made in the programme. In addition to that, what the chairman asked was that people who would come forward, with experience of services, staff members, etc., in order to provide some perspective on their experience at Carsview that we could also take into account, particularly when BBC spoke about not only the people who appeared on the programme, but also those who had they had identified as having approached them or spoken with them. I think there were something like 23 people that they talked about. So the chairman clearly wanted to ensure that people had an opportunity to give a more direct feedback in terms of how we were responding to some of these issues. So the BBC agreed to approach the people and advise that if there was a named contact, and my name was given as that named contact, and there was a confidential phone number and email address for people to contact, then they would feel safe to do so without necessarily being identified. So what I did in addition to reviewing data and evidence was actually I met with a significant number of these people that then came forward. We had something in the region of 22 people that came forward. I did not seek to identify whether in fact they had been in contact with the BBC or not, so I have no way of knowing that, and I didn't think it was particularly helpful to hearing about their experience to actually pursue that line of inquiry. So really it was a case of just taking that information on board. So as part of the assessment process, the experience of patient service users has been brought into that framework. So I can assure you, and it was a very supported framework, and I'm pleased to say that people like Jackie Pepper and the other chief social work officers provided contact, so that if there were any issues that came from that needed to be taken forward as a kind of vulnerable person type issue, then that network was there to support that work as well. And part of the issue is, in terms of trying to conclude this piece of work, is that we have to go through significant information governance procedures in order to be able to include these case studies in the report that's then going to be produced at the end of all of that assessment of the data and evidence and those experiences. So we have actually written back out to everyone to seek specific consent so that that testimony can be included in the work.
Okay, thank you.
Okay, any other questions on this spot? Mrs. Cam.
Thank you. In relation to... Oh, that's me. In relation to 4.1, and obviously it talks about the first 3 moves are underway. Back in January at our IJB, I know the public partners had requested or had raised the point of the people from Perth and Kinross, or patients from Murray Royal, being moved to Cast View, and we'd asked that this didn't happen until the refurbishment programme had taken place, and I think we'd got agreement to that. So it's in relation to that, with regard to the financial implications, and having listened to obviously this morning and the concerns regarding future budgets, etc. Has there been money allocated for this, and where is it coming from?
So thank you for your question. The enabling works for the changes for people are absolutely dependent upon environmental change. So the move, first of all, to Faskerley Ward doesn't require that much work, because that's an existing modern building that has facilities that are fit for purpose, from my understanding. As we start to think about any moves from Carsview into Strathmartin Hospital, there will be enabling works that will be required. Similarly, as we consider the move of people from Murray Royal to Carsview, there are significant enabling works that need to be done. So the programme director who's looking after all of this practically, Lynn Hamilton, who I think you have met before, has been in contact with the Director of Finance for NHS Tayside, and arrangements are being put in place to make sure that those moves can happen in a timely fashion. However, there are many practicalities around that, and much as Alan has described the workforce issues, these too will be rate limiting. And so therefore, the work that's ongoing at the moment is to try and make sure that that is properly sequenced, and that people are not in any sense disadvantaged by moving from an environment that is, or to an environment that's not suitable. Thank you.
Okay, Mr. Drummond again.
Sorry, can I just add to 4.3? We had the first meeting yesterday of the Employee Participation Group. We met with Mr. David Strang, who's chairing the independent inquiry, and we were agreeing yesterday our terms of reference and role of remit the group. So we've got a further meeting on the 10th of October. It's just to give you a wee bit of an update on the back of that.
Thank you very much. Have we got any more questions for the Chief Officer on his strategic update? Oh, I beg your pardon, a bit more.
Just two more things to talk about. There has been a request from the Scottish Government on the review of local governance, and at a development session that we had up at PRI, we made an attempt to have a discussion about this, but just felt not to be extensive enough. So we are going to be setting up another session in October for members of the IJB to put their thoughts forward on this matter. Okay? And the final thing was just to say that yesterday at the Health Board, we had a very persuasive presentation on the preparations for winter. And in particular, the importance of people having their flu jab. And so I am just taking the opportunity while I have the microphone to say to you, if you haven't had your flu jab, please do. And I worked it out this morning that if we had 50 people in this room and they had conversations with 5 people, and that happened 5 times, we would cover the whole of the population of Perth and Kinross. And we should be promoting this to the population, because by keeping ourselves well, we help prevent vulnerable people from becoming ill. And that's very important in terms of managing the workload in the coming winter. So forgive me for that, but I think it's an important point. Thank you.
I don't think we should forgive you for that, Rob. We should thank you for that, because I think that's a key message that needs to go out to the community across Scotland.
Thank you.
Okay, Mrs. Pepper.
Just on that, something I think that could be done is we could do some publicity around that. In fact, if you and myself, Rob, were to pitch up and have a vaccination and put that into the media, then I would be quite pleased to assist you with that.
I'm not having a second one, Jackie. We did exactly that yesterday. And to be honest, I mean, for the members of press in the room here today, this is a really important message. I'd love to see that on the front page of the newspapers. If we can do something that will make a difference to the population here in P&K, and actually you only have to go to that conversation happening 9 times and you cover the whole of the population of Scotland. So let's do what we can.
Okay, just to emphasise the point, when we had the update at NHS Tayside Board yesterday, a key element of preparations for winter is trying to keep people unnecessarily out of, or keep people out of hospital, keep them from entering unnecessarily. And a key part of that is protecting older, frailer members of society from flu and the importance then of the vaccination programme. But if there are no more questions for the Chief Officer on his update, we'll move on to the next item on the agenda. Okay, so we're now going to talk about programmes of care. The first one of these is the Primary Care Improvement Plan and General Medical Services Contract Implementation. We have got a progress update. I've got Dr. Dougal. Do you want to introduce the paper and take any questions?
I'll just speak very briefly to it, really. At the last meeting, we presented the Tayside Primary Care Improvement Plan to you for approval, and this is just taking it a step further, putting a bit of flesh around the bones that was presented. This is by no means a finished product. We really need to go out and engage right across the localities and define what the best model within those localities for the services for patients in support of primary care is best, and we will keep coming back with updates on that. You'll see on the table 1 there, the fund that's been allocated across the 4 years. Years 2, 3 and 4 are indicative, but those are the expected funds that have been identified from Scottish Government. It's probably worth highlighting amongst all the conversations on financial pressures today that this is a ring-fenced fund that's been specifically commented that it's not available for addressing wider pressures. And it's really meant to be entirely in support of establishing a sustainable primary care base. Whilst it is about supporting predominantly the GP workforce, I think this has huge potential benefits which are much wider for patients amongst all of these different areas. And I'll probably particularly pick up the conversations we'd had earlier on GP prescribing, partly due to resource and also lack of recruitment. The number of pharmacists working within practice who can directly influence prescribing will hopefully be increased with a full complement by something in the region of 125%, from about 8 up to 19 across P&K, which will hopefully have significant benefits in terms of getting a grip on our GP prescribing. We're working with the Action 15 funds under mental health to provide what I think after 20 years of general practice will be the most significant change in the services that are being offered to patients at the grassroots within primary care, and I think it's to be really welcomed. I'm very happy to take any other questions on the paper.
Thanks very much, Dr. Dougal. Are there any questions? Mr. Fellows.
I think to say first and foremost, I was quite pleased to see reference in respect to the requirement and I suppose intent to develop the advanced nurse practitioner role as part of this model. That is a national strategic drive with Scottish Government and Chief Nursing Officer supporting the development of 500 new or additional advanced nurse practitioners. I have some anxieties though, and I suppose I'm looking for a degree of assurance that we are absolutely being overt in terms of our workforce planning, in terms of the numbers that we're predicting. So 11 advanced nurse practitioners is not insignificant, so I think that's a first point. I think that there's a real appreciation in respect to the realistic timeframes that it will take to develop an advanced nurse practitioner or 11. They are not available off the peg out there at the moment, and that's our experience throughout the other areas in Tayside. And I think thirdly, I suppose, an assurance that the lead nurse for the Health and Social Care Partnership is absolutely up the middle of that. It takes 3 years to educate and train an individual from base level to become an advanced nurse practitioner. 2 years for somebody who's got a bit of experience. We need to be on the front foot right now if that's the target, and that's a plan, and that's my plea.
Yeah, absolutely. In terms of lead nurse, she sits on the primary care board for P&K, so she's absolutely in and through this. In terms of workforce planning, this is a huge challenge, which I absolutely recognise. It's not just confined to our ENPs, it's combined, it also applies to our pharmacy teams, our mental health teams, all other aspects of the plan. I think it's one of the main risks of the plan is actually getting the workforce in place. So absolutely we do need to be planning ahead for that.
Okay, any more questions? No, so if that's okay, then with the board we'll note the proposed allocation of primary care improvement funds across the programme of projects seeking to implement the primary care improvement plan and the 2018 General Medical Services contract, and we will request further reports to each sitting of the board as the implementation programme develops. Agreed? Agreed? Yep, great, thank you. Okay, next then, 5.2 on the agenda is a review of day services, an update from the Chief Officer, Mr. Packham.
Thank you, and I'm just going to defer to my colleague Diane Fraser, who's the Head of Adult Social Care and Social Work.
Thank you. This report provides an overview of the progress of the implementation redesign of day services, which was approved in September 2017. The review set out clear aspirations to continue to maintain high quality day services and day opportunities within Perth and Kinross, providing targeted structured daycare within a modern environment suitable for the mix of complex needs that we have. And this was to be underpinned by the new health and social care standards. A significant element of the redesign was the merger of Lewis Place and New Ranach, which is within older people's services. The merger was concluded in March, following comprehensive engagement with staff and service users over a 6-month period. We engaged independent advocacy, as you'll see in the appendix, to support engagement with service users and their families. And we continue to develop the community-based support and continue to develop outreach models for day services in the spirit of the self-directed support legislation. Finally, the Care Inspectorate were engaged throughout the process, and our most recent inspection has reflected a grade of level 5, which is highly commendable given the significant change that's happened within the two units.
Okay, thank you. Are there any questions on this report? Councillor Jarvis.
Yes, reading this report, there's a lot of good progress and implementation for the future. But can I ask a question specifically about the vaccination programme? It is quite difficult sometimes to get people to take up vaccination, and I just wondered what the effect might be of removing it away from GPs into the actual NHS board and make it their responsibility.
I think that might be a question on the last report, but we'll let Dr. Dougal answer anyway.
That's in fact what's happening. Part of the new primary care improvement plan is to take vaccinations away from primary care and to have a pan-Tay-side approach to vaccinations. The first year is consolidation, but thereafter all of the seasonal vaccines and the wider vaccination programs will be the responsibility of a pan-Tay-side approach.
Okay,
sorry, I think I must have misread that. I was assuming that it was being taken away from GP services, so
okay.
Apologise.
Thanks, Councillor Jarvis. Any more questions on review of day services update, or can we note the progress achieved so far? Oh, Mrs. Pepper.
I just wanted to make a comment that this is a very positive report and that you know, savings have been made, but there's been actually an increase in the level of provision and the quality has remained high. So I think it's a very positive report and it should be commended.
I think actually that was, when I was reading through these reports for the pre-agenda meeting, I think that was something that was that leapt out, was the fact that, as you say, we were achieving savings, but actually increasing the level of service provision. And absolutely, all your colleagues there are to be commended for that. Nope, we note that report. Okay, so the next item on the agenda then is the annual performance report for 2017-18. I think we have to note with this report that it was approved by the Audit and Performance Committee on the 19th of July and submitted, because it was required to be submitted to the Scottish Government by the 31st of July 2018, but I think everybody had the opportunity to feedback on that. We saw a draft at the last meeting, if I'm not mistaken. So I think it's really more just for noting the fact that that was the final version that has been submitted, but if there were any questions on it, we could open it up for that. Comment, Councillor McKeown.
Just yesterday I spent a couple of hours with a constituent who, through our housing team in Perth and Kinross, is currently looking to move house from our family 3-bedroom house, which she lives in by herself, to a smaller accommodation with the council. And this lady has mobility issues. That's one of the reasons for the move. It's likely she's going to be offered a brand new property. However, that brand new property that's currently being built and fitted out will be fitted out to the builder's standard and how the builder wants to do it. And then we will have to adjust the building and the kitchen and the bathrooms to meet her needs. And at the moment, the discussions that are happening with this individual case means that the constituent actually might not accept this new home. And all the standards and all the things that are mentioned in this paper about independent living meet her. You know, it describes her perfectly as a case example. And it just seems that there's a bit of a disconnect here. I'm bringing it up with the housing within the council, but there seems to be a disconnect here where we're building brand new social housing, specifically for patients with medical needs, and they're getting built to how the builder would want it, fitting the needs of people like ourselves here, rather than the needs of that actual individual. And there's now going to be oncurring costs, whether to her as an individual or to the council, to then re-alter that brand new house to meet her needs. And there seems to be wastage in that sort of setup and the way that's proposed. And I just wanted to, you know, sort of highlight that there's still work between the different factions within the council and with this board to look at how these things could be more joined up. Because the house as it stands at the moment should be moving from somewhere that's unacceptable to somewhere that's unacceptable. One thing she's mentioned to me is that because the house is brand new, there's certain alterations she cannot make for a year. Because it's a brand new building, if there's any building defaults, it would fall back to the builder to fix them. If she makes any adjustments, then if there's any building errors, it won't fall back to the thing. So there's a join up here. I just wanted to raise it as a point to this. That
Okay, thanks, Councillor McEwen. I think you might have skipped ahead to item 6.2 on the agenda, but we'll, if there are no other remarks on the annual performance report, we'll move on to 6.2. Just for clarity, this is this is the paper whose title is longer than no, it's not longer than the content, but it's a close-run thing. The Perth and Kinross Joint Strategy to Support Independent Living and Quality of Life for Adults with a Physical Disability and or Sensory Impairment 2014 to 2017 and associated implementation of the National See Here Sensory Impairment Framework 2015 to 2018. It's maybe worth just, I'll invite Diane to come in on this. Maybe it would be useful to reflect on some of the points that Councillor McEwen raised. Councillor McEwen, thanks for bringing those as an example of a constituent. It's useful to bring those issues forward to crystallise what's in here. Just remember that we are being recorded. The other thing that I would just say in response initially to your comments is that I know that I attended the opening recently of a new social housing development in my ward, and out of the total number of properties there, four I think out of 20, or approximately that number, were already equipped for easy access, and that some of them had already been built with future-proofing in mind, so strengthened joists, partition walls that would be easily removed to create better flow between areas. So if you're taking it up with the housing department, in the particular example of the site in your ward, I know that for other developments that future-proofing is and has been going on. But I'll bring in Diane Fraser now as Head of Adult and Social Work and Social Care to talk a little bit about this report.
This report really highlights the progress that's been made from the strategy that was introduced in 2016. It highlights the progress that we've been working around with the third sector, around employment, around with Vision PK and action on hearing loss as well, and creating a one-stop shop. We're certainly working with housing and other partners in relation to future-proofing, as Councillor Stewart had, properties which will be more accessible to individuals. So we've been working very closely with Claire Mailer from a housing department, and she will be bringing forward a report to the IJB around the work we've been doing around older people specialist housing, and also around other specialist housing and the developments that that they're working with the local community with. So they should be coming forward.
Okay, thank you. Are there any questions or comments? Councillor Drysdale.
Yeah, thank you. I've got 2 or 3 questions actually on this report. Just picking up on the housing issue first of all, and you know, I see the progress that is planned to be made going forward. However, if I'm reading the figures in the appendix correctly on pages 178 and 179 of our papers, the number of houses available for wheelchair users has fallen between 15-16 and 16-17, which are the last figures available. And in that regard, and I feel I should know the answer to this question myself as I'm on the Planning and Development Management Committee, but I wondered whether as a council, PKC has a joined up approach, and that the local development plan 2, which is in the process of being approved, whether there is a policy therein that that makes it mandatory for new builds to include a certain number of adapted houses, or whether that is practical. So, I mean, I have a concern that, as I say, that the number of houses available for those with that are wheelchair users has reduced, and wonder how we're going to go about addressing that and turning that around. That was question one. A comment regarding accessible transport. I note that the licensing board or committee is looking to make it mandatory for taxi drivers and to obtain training on wheelchair access to vehicles, and I would encourage the licensing committee to go ahead with this. My final question, from bitter personal experience and knowledge of other individuals in the same situation, I wanted to focus on the health section of the progress report that's been given here, and I wonder what attention is being paid to how people with disabilities, physical disabilities and communication difficulties, when they are presenting with physical issues, are able to be accommodated within mainstream hospitals. My personal experience, as I say, is not favourable. And I would like some sort of comment on what's been done in that area. And also on the health-related issue, I'm aware of efforts by local people to create a play park for children with disabilities at North Inch, and an ongoing struggle to obtain necessary funding support for that. And I just wondered whether this body has any involvement in pressing for that development to take place. Sorry to ask so many questions all in one statement.
Okay, who would like to deal with the first of Councillor Drysdale's 27-part question? No, Mrs. Fraser? So what we've got, the number of houses suitable for wheelchair use and the drop-off between 2015-16 and 2016-17?
Unfortunately, I'm not able to provide that information, but I certainly will offer that following this meeting.
Okay. The licensing board issues about... Comment. Okay. Okay, health aspects.
Thank you, Councillor Drysdale. I mean, clearly the NHS has procedures for dealing with people with all manner of physical, cognitive, visual, sensory impairment. And we do have mechanisms by which staff can call upon support when specific types of support are required, particularly thinking of communication and the needs of those with sensory impairment. We have people whose role it is to make sure that the equality of access for people is absolutely a focus within the NHS mainstream services. And within our own services as we deliver them, we have access to all of those same support services. So if I can offer to speak to you about the particular issues that you've encountered yourself and the experiences that you feel do not work very well, I can see what I can do to understand that better and to make sure that that's communicated back. However, equality of access, dealing with people who've got specific deprivation of access, for whatever reason, is very much the focus of the partnership, and we need to think about that in the way that we design services. Listening to our carer and service user reps, very important because they bring a perspective to the real experience of the people who are using our services, and we're offering increasing amounts of opportunity for the service user service user and carer representatives to put into our planning processes any thoughts, any concerns that they have about these sorts of matters, so that we can consider them in our planning. But there is almost no point in having a health and care service that does not allow people to access it, whatever their needs. So it's right at the root of our core purpose, and if we're getting that wrong, we need to know about it and act and respond to the lived experience of the people who are here in P&K.
And I wonder if I could just add to what the Chief Officer was saying about the involvement of service user and carer public partners in design of services. It's obviously critically important that we design services around the end users of those services. And it was very encouraging to note that at the recent Transforming Tayside session that we had at the North Inch Community Campus a couple of Saturdays ago, as part of the overall Transforming Tayside programme, that those involved are taking a design-led approach, which starts with the user and works back the way, rather than sort of taking a top-down approach. And the work that's ongoing within NHS Tayside and the Transforming Tayside programme, if that's replicated, if that model was replicated, then I think that you would have the assurances that you're seeking in that respect, Councillor Drysdale. Mr. Brown or Bill, Mr. Nicholl, did you want to come in?
It was maybe just to kind of add to the points about the person-centred approach. We have a person-centred board within NHS Tayside. We have a head of equalities and human rights whose job it is to make sure that NHS Tayside fulfills its public sector duty responsibilities to people with disabilities, etc., or disadvantage. In fact, the new Fairer Scotland duty that came in the 1st of April is actually related to socio-economic disadvantage and adds to the other characteristics that we have to take account of. So in future service planning, we have this person-centred approach alongside an absolute duty to fulfil, and we've got to be able to demonstrate that we actually take account of all of these things when planning future services. I think the other thing, just briefly to mention, is that you may be well aware of, Chairman, is the remit that the board chairman gave to Drew Walker and others to take forward a design programme that's looking at how we improve accessibility and how you know, health literacy, which is more than about literal version of that. It's about how people actually navigate their way through services. It needs to very much take account of the kind of issues that have been raised about access, and it's something we do need to focus in on and improve.
Okay. Any other questions or comments on this report? No. So we've got 3 recommendations to note the delivery of the final actions contained in the strategy and the associated implementation of the National See Hear Sensory Impairment Framework, and note that a commissioning plan to support independent living and quality of life for adults with physical disability or sensory impairment will be included within the Older People and Unscheduled Care programme during 2018-19, and to instruct the Chief Officer to provide a progress report to the board in 12 months' time. Are those recommendations agreed? Agreed. Thanks very much, Councillor Drysdale. Getting in the spirit of things. 6.3 on the agenda is the Care Inspectorate inspections for 2017-18. Going to get Diane Fraser again to speak to this report.
Thank you. This reports the key findings of the inspections that have been carried out in Perth and Kinross during 2017-2018. It reflects the very high standards and quality of services that we aspire to in Perth and Kinross. I would like you to note that we have seen improvements in care at home, and the care and support being provided within our HEART team has been of a level of grade 5. And again, this is another service which has been through significant change over the last 12 months, bringing together 2 different sets of staff groups. So we've been doing a lot of work around the workforce, and they've still been able to continue to deliver the service under increasing pressures. The report also highlights the outcome of inspections within care homes as well, and again we're retaining good quality standard within our care homes and also within our housing support services.
Okay, thank you. Are there any questions? Dr. Pete first.
Clearly a very positive picture in terms of the provision locally. Could I just ask for a point of clarification? These are services which are directly delivered by the partnership?
Yes.
That's the case. Could I then ask, in terms of the services that are delivered from other providers in the area which may be commissioned by the partnerships, do we see a report which actually reflects the level of performance in relation to those providers?
Yes, that was a request actually by our Chief Social Work Officer, so that will come forward to the IGB.
Thank you.
Councillor Drysdale?
Spookily, that was exactly the question I was going to ask.
Any other further questions or comments on the report? Did you want to come in, Chief Social Work Officer?
Yes, really just to say that I think this is, again, a very positive picture, and just reflecting that the new health and social care standards which came into force in April 2018, and it's really helpful to see those being reflected here. I think Dr. Pete, as former Director of Inspection of the Care Inspectorate, will recognise that to have that profile in terms of the number of excellence and very goods for a small number of services is actually quite exceptional, so a very positive report.
Dr. Pete.
Absolutely. You know, to achieve excellent in terms of the highest standard that actually the Care Inspector will award is well, I was going to say it's very good. It's obviously excellent. So maintaining that is really important, and I think also for services, hopefully they will, and I'm sure Diane will ensure this happens, that actually services will learn from one another. But it's key to how you maintain the excellent. And I think also for the Care Inspectorate, in terms of their assessment, and they can help with this, but actually how you get from very good to excellent. So it's really important to actually be able to define what excellent is, and how you continue with that, but also to enable other services and learn from those excellence and move that into the services that are perhaps not performing as well as they could.
Okay, any more questions or comments on this one? Right, well, in that case, if we can agree to note the report, and I think pass our congratulations and thanks back to the staff involved on the gradings that they've achieved. If that's okay with everyone. Okay, 6.4 on the agenda then is the Adult Protection Committee biennial report. I'll ask Jackie Pepper, as Chief Social Work Officer, to speak to the report, but I would just like to say that it's planned that a future development session of the board will have a joint presentation on child and adult protection to describe the work ongoing around that. This report also has been signed off by the Child Protection Committee, and they, because it was required to be submitted to the Scottish Government, we would have looked perhaps to bring the report at a development session with a bit more description and presentation work around it, but it fits much neater if we do the child protection and the adult protection presentation at the same time. So we're seeing the report now, but there will be further work on that. But Jackie Pepper, if you'd like to just speak to the report.
Thank you, Chair. Thanks for that introduction. Very pleased to introduce this biennial report of the work of the Adult Support and Protection Committee to this meeting of the IJB. And just for clarification, that it has still to be submitted to the Scottish Government, so it's very positive that this is coming here prior to that. It's a legal requirement to produce a report every 2 years, and the adult protection is delegated to Perth and Kinross Council by the Perth and Kinross IGB, so this report will also be considered by the Perth and Kinross Council at its next meeting on the 3rd of October. This report demonstrates a commitment by the Multi-Agency Adult Protection Committee to continuous report, and I think this report reflects a high degree of honesty in terms of both what's working well but also the improvements that need to be taken forward. And notably within this report are the changes in trends relating to a reduction in numbers of people for whom there are concerns being expressed, and also the numbers of people who are progressing through the various processes associated with protection. And this will be an area of focus for the Adult Protection Committee in the very near future. And in fact, the committee itself already has plans to consider this in the light of the thematic report on adult protection that was published by the Care Inspectorate over the summer. Very positively, I think you will see that there's been a substantial increase in the delivery and uptake of training. And also just to notify the IJB that in terms of reviewing the role of the Chief Officers Group, which is referred to in the improvement plan, I've already had a discussion with the Chief Executive, the incoming Chief Executive to Perth and Kinross Council, Karen Reid, and we'll be reviewing the arrangements around reporting to the Chief Officers Group, so that's already in hand. And as the Chair has suggested that this report recommends that we have a development session which focuses much more on public protection, on both adult and child protection, recognising that people live in families, and that may be a very useful opportunity to enter into some questions around the detail of the report itself.
Okay, thank you. Are there any questions or comments on this report? No? Okay, can we agree then to note the contents of the biennial report to be submitted to the Scottish Government, request a report on the activity of the Perth and Kinross Child Protection Committee over 2017 to 2018 to our next meeting, and request a development session to be held on the subject of child and adult protection by the end of November 2018. Is that acceptable? Yeah. Thank you very much. Okay, so that concludes the substantive matters before us. Can we note then for our future meeting dates that we have a briefing session on Friday the 26th of October. I think we are planning to take ourselves to Crieff to combine a look round the facility, look round some of the facilities there with some of the other development activities that we've got planned. And then our next board meeting will be on Friday the 30th of November. I think we've also got a development session planned in for, at the moment the date is the 21st of December, but we think that we might bring that forward slightly from the 21st, maybe to the 14th. So those are the next meetings, if those are okay. Yeah. The next item is item 8, proposed 2019 board meeting dates. So we've got one thing to note here, which is the shift to Wednesdays. Everybody was asked about that. There was broad agreement that that would be suitable for everybody. Just to explain that for councillors in particular, a lot of the other external meetings that we're required to attend fall on Fridays, and so we wanted to make sure that we were here as much as and available as much as possible, and certain Wednesdays, which is our routine committee meeting day, had freed up. So if those dates are all acceptable, we'll get those in the diary. Dr. Pete.
You've heard earlier that will be the chair of the IGB. Unfortunately, I can't manage 2 of these dates, so I wonder if I could ask that 2 of them be changed.
Okay, yeah, absolutely. We'll look at that.
Okay, thanks.
Can Can I
Mr. Ferris.
just make a point? I cover and support 2 integrated joint boards, and a Wednesday will clash significantly with Angus, so we may need to look at its other committees.
Okay.
But
take that into consideration. And Mr. Drummond.
I think I've already raised this with Scott. The concern would be area partnership forums are core business for NHS Tayside, and they are Wednesdays. I appreciate they're not every Wednesday or even bi-monthly, but obviously the staff side meetings, APF, are also Wednesdays, and a lot of the workforce and governance meetings are also Wednesdays, but I think the majority, and if the majority are saying obviously changing from Friday to Wednesday, well obviously so be it, because
Okay.
Fiona Fraser might be able to attend.
Thank you. Okay, so that concludes the business before us today. We have got a development session on the self-evaluation process. Oh, sorry, Mr. Brown.
Sorry, just before we conclude, I would just like to put on record my personal thanks to Stephen Hay for his work as the chairman of the IJB and for the support that he has given me as the vice chair of the health board in the 6 months I've been here.
Okay, thank you. Yep. So I'd also like to note the time and effort that Stephen put into the board since he took over as chair earlier this year. That's one valedictory, but we do have another valedictory. The clerk to the board will be leaving at the end of November, but I think this is her last full meeting as clerk to the board. Gillian has spent, Scott informed me, more than 60 years in local government. No, it can't have been that many. 23 years in Perth and Kinross Council. And a substantial number of years in local government before that. She was a key advisor to the Pathfinder Board and has been clerk to the Integration Joint Board since it was set up formally in 2015. So I think we would all like to recognise Gillian's contribution to the board, and we have a little something for noting this momentous time. Rob, if you would like to pass that on.
Thank you very much. That's very kind. That's very kind.
Okay, so that's the meeting concluded. If I could just remind everybody that we have got a development session on the self-evaluation process immediately. Immediately afterwards. But thank you all for attending for the formal business of the board today.